Good evening, everyone. I am Dr. Monica Darji, General Manager for Scientific Marketing at Unipath Specialty Laboratories, and it is my privilege to welcome you all to the inaugural session of this webinar series, Decoding Genomics for the Unborn. This academic initiative is brought to you by the Fetal Medicine, Perinatology and Genomics Committee in association with the Obstetrics and Gynecology Society of Hyderabad, powered by Unipath Specialty Laboratories. Today, as we begin an important journey, bridging clinicians, reproductive specialists, geneticists, and fetal medicine experts together to strengthen the genomic understanding and improve patient care. We extend a warm welcome to everyone joining us this evening. Your commitment and time are invaluable. The guest of honor for this webinar series is Professor Dr. Shantha Kumari, Madam. She is a visionary and the person behind all academic activities that OGSH has been spearheading. She's an iconic figure in obstetrics and gynecology, women's health advocacy, and minimally invasive surgeries. We are blessed to have her as the guiding light. Let me now introduce Dr. L. Jayanthi Reddy, the president of OGSH. I'm pleased to introduce her as a consultant gynecologist and director, JJ Hospital, Hyderabad, with an MD, DGO, DNB, and FICOG, and an award-winning academic record. She has built a distinguished career anchored in her clinical excellence, teaching, and women-centric care. Dr. Reddy has served as an assistant professor at Government Maternity Hospital. She continues to mentor young clinicians as a visiting faculty at SBS Medical College. Her academic excellence was recognized early in her career with the Young FOGSI South India Oration Award. As President OGSH, she continues to drive impactful academic collaborations in women's health. We are delighted to have her here. Madam, I invite you to say a few words. Jayanthi ma'am, if you can say a few words, please.
Thank you, Monica, for your kind words. And I congratulate all of you, along with Shagun, for Dr. Shagun, for creating this webinar series. This is a very, very important thing because we need a real understanding, because when we were undergraduates and postgraduates, at least for the seniors, we didn't have that much amount of exposure to the genomics. And in between, what has happened is the whole world got the genomic study created. We understood what are the human genomics. And with that, then every disorder, there is a genomics associated with it. You take PIH, you take anemia, you take recurrent pregnancy loss, infertility, cancer, everything you talk about will have its genetic basis. So how we were talking about immunology, now we are talking about the genetic basis of all the disease. So it is very, very important as a gynecologist that we should have a clear understanding of the genomics. And this web series definitely is going to throw light and give us a clear understanding of various aspects of the genomics. Thank you once again. Welcome you all for this webinar series.
Thank you so much, ma'am. Thank you.
Thank you for your kind words, ma'am. Next, I would like to introduce the Secretary OGSH, Dr. Manjula Rao.
Hello.
I hope her slide is visible. Thank you. So it's a pleasure to welcome Dr. Manjula Rao, Senior Consultant and Head OBGYN at Durgabai Deshmukh Hospital with an MD, FICOG, FMAS. She has contributed extensively to the national guidelines, academic programs, and antenatal care standards. Nationally, she has served as an examiner for the National Board of Examinations and was formerly a reviewer for the JOGI. She was also a contributor to the FOGSI ICOG Good Clinical Practice Recommendations on Routine Antenatal Care, a widely referenced guideline across India. Her academic contributions include multiple publications, and she is an active faculty member at various national OBGYN conferences. Her expertise spans multiple maternal fetal medicine, antenatal care, and evolving domain of reproductive genomics. As a secretary, OGSH, she plays a pivotal role in professional engagement, academic strengthening as well. We are honored to have her here. Madam, I invite you to say a few words. Manjula ma'am.
Yeah, thank you. Thank you so much for those kind words. I'm extremely glad that this web series is started, and Dr. Shagun, who is heading the subcommittee of OGSH, has taken the initiative. I'm extremely happy, and I'm sure it'll be a great series. And I have seen you in academic conferences in the past, and you are a great academician, and the way you talk and all. I'm sure you'll simplify a lot of things for all of us OBGYN practitioners. So my best wishes to all of you. And of course, thank you for the support, Unipath Lab. Let's get started, I think.
Thank you, ma'am. Next, it's my privilege to introduce Dr. Shagun Aggarwal. She's the professor
brief,
and head.
Monica. Keep it brief. We'll start.
Sure. She's a professor and head of medical genetics at NIMS and adjunct scientist at CDFD. She's a convener of the Fetal Medicine, Perinatology and Genomics Committee of OGSH, and for this webinar series as well. Ma'am's introduction is very, very big, huge, I would say. So I'll not take much time. I think everyone can read it. And it's a privilege to have her guiding this series. Ma'am, I invite you to say a few words, and then we'll start the session.
Thank you so much, Monica. So good evening, one and all. And I mean, at the outset, I want to extend my thanks to Dr. Shantha Kumari, Madam, Dr. Jayanthi, and Dr. Manjula for giving this opportunity to our subcommittee to organize this webinar series. So this series is basically meant to decode the genomics code, which to many obstetrician, because I'm from obstetric background, and I know as obstetrician, genetic the ATGC and the rest of the genetics appears like Greek letters to most of obstetricians. So I've been there, but yes, the purpose here is basically to understand how this is really important in today's era in our day-to-day clinical practice in most of the common clinical scenarios like recurrent pregnancy losses, bad obstetric history, ultrasound anomalies, Down syndrome screening, infertility, and so many other scenarios actually. So in practically every situation you come across in a OBG clinic, there would be a component of genetics, and it's the era where this is something which now patients are becoming aware, and very often they come to the practitioner and they are asking questions. So it's time that everybody needs to kind of come on to board and understand how to use this for practice, and it should not remain kind of a theory. So this whole series will take you through cases, and in the first webinar we'll focus on recurrent mishaps in pregnancy, and I really hope that everybody finds this a enriching learning experience. So I think we should start now.
Thank you, ma'am.
Yeah.
I will just, for the benefit of the audience, I'll just quickly go through the housekeeping rules. One, except for the presenters, faculty members, and moderators, all the attendees will be on mute to have an uninterrupted session. How to ask questions? So any of the attendees can use their chat boxes or Q&A boxes anytime to ask the question, and we'll be taking them at the end of the session. We will have live interactions as well. So when during the Q&A segment, we would request you to raise your hands so that we can unmute you and you can ask your question. We will be also sharing the recording of this webinar within the next few days. Thank you so much. So this brings me to the first session, that is the couple with recurrent first trimester miscarriages. So I'll quickly come on to it. And this session is going to address recurrent first trimester miscarriages with a case study. And I'm pleased to welcome our faculty members, Dr. Shagun Aggarwal and Dr. Meera Rajagopal. Let me introduce Dr. Meera Rajagopal, HOD OBGYN Vijay Mary Hospital and Medical Director, Akshaya Fertility Center. With an MD MRCOG London, a global experience including some hospitals at UK, she brings a deep clinical and reproductive genomics insight. She's an active member of ESHRE, IFFS, ISAR, and FOGSI. So this case, which is now being presented, is presented to you by Dr. Wali S., Medical Genetics Resident, Department of Medical Genetics, Nizam Institute of Medical Sciences. Over to you, Dr. Wali, to present your slides. Thank you.
Thank you, ma'am. Thank you for the introduction. Ma'am, shall I share?
Yes, please.
Yeah. Are the slides visible, ma'am?
Yes, Wali, please go ahead.
Yes, ma'am. So, yeah, good evening. I'll be presenting the first case scenario, a couple with recurrent first trimester losses. So, this is this non-consanguineous couple who were married for 5 years, A3P0L0. They were referred for recurrent first trimester miscarriages and fetal anomaly in one of those pregnancies. No known comorbidities in either partner. And there was history of primary infertility in female partner sister without any, no other relevant family history or known genetic disorders in the couple's family. So this is the pedigree of the couples, basically the family pedigree.
So Dr. Wali, before
Yeah.
I think, most of the audience here will not be familiar with what this is. So can you just briefly tell us what are these various circles and squares which we are seeing here?
Sure, ma'am. So this is that the male individual is represented as a square. So square for male, circle for female, and diamond when the sex is not determined, or in case of a DST, or even in pregnancy, we make a diamond and we write P inside. And when the number of individuals is not known, we just make a square, and number of male individuals, then we write the number 2, 3, or N. And a relationship status, if it's a single line, it is non-consanguineous marriage. If it's broken, the line is broken, then they're separated or divorced. And double lines represent consanguinity. Triangle, it's spontaneous abortion. Triangle with a slash, that is termination of pregnancy. If it is not shaded, it is usually for personal choice. If it is shaded, then terminated in view of some anomaly or abnormality which is documented. And this is just briefly, I'll just talk about these symbols also. Like multiple gestation usually will give like a branched one, like depending upon the zygosity. If it is monozygotic, we'll add a line, horizontal line in between. If it's dizygotic, we don't add anything. And trizygotic determined by this, like the symbols. And also the reproductive scenarios for surrogacy and all, we make the circle or circle and then write S inside. And these are all just basically the reproductive scenarios. Adoption, if it is broken, the line is broken, it is adopted in. If it is discontinuous, it is adopted out. No children by choice, one single line, horizontal line. Double lines indicate infertility, usually primary infertility. And carrier, this is female carrier per circle, and we put a dot inside. So this is just the introduction, or just to tell the symbols, various symbols that we use in pedigree. Now coming back to this family pedigree, the couple's family pedigree. So here this arrow indicates, and C I have mentioned, which is consultant. This is a consultant couple. He is 30 years old and wife is 26 years old. They were married for 5 years, and they had 3 abortions, and one of them was a termination of pregnancy. And though the complete details were not there, based on the history, it was like neural tube defect. And the other 2 were spontaneous losses. And in the wife's family, her sister was married for 3 years. They also were not having children, so the couple. And there was primary infertility in the wife's sister. And the other family history. So here, this 3 generation. Here we can see that there is no significant family history. And yeah. So moving on.
So now I think I will ask my co-moderator, Dr. Meera. So like this is a couple, we see that there is nothing really very significant in the family per se. So, and we have this, couple having these miscarriages. So As an obstetrician now, what all investigations do we do here now for this couple to look for the cause for these miscarriages?
Right. Good evening, Dr. Shagun and others. First of all, thank you for inviting me to be a part of the webinar. So the answer to this, the acquired causes of RPL in the first trimester. So we would first look at what is called acquired thrombophilias, which include the most common acquired thrombophilia is NAPLA, where these antibodies cause intense trophoblastic clotting and necrosis, and these antibodies also have trophoblastic dysfunction in other ways, like activating the complementary factors by activating the immune inflammatory response. All this will cause large apoptosis of the syncytial trophoblast. So the next causes, the next few causes are endocrine ones, like we are looking at a thyroid dysfunction. Subclinical hypothyroidism also causes. We're looking at hyperprolactinemia, which has a bearing on the hypothalamo-pituitary axis, and this may lead to defective folliculogenesis, impaired oocyte quality, LPDs. And we are also looking at uncontrolled diabetes, not controlled diabetes, where the hemoglobin A1C is very high, and the risk or the percentage of miscarriages is related to the percentage of hemoglobin A1C. And we are looking at PCOS, where there is intense androgenic environment and a buildup of reactive oxygen species in the ovary because of insulin resistance and hyperinsulinemia, leading to bad oocyte quality. And we are also looking at lifestyle factors which are related to RPLs, like obesity, excessive alcohol, smoking, as well as excessive caffeine consumption. Finally, the ESHRA guidelines have recently included even male factor contribution, like sperm DNA fragmentation or sperm DNA damage. So these are the few causes from the obstetric point of view which contribute to RPL in the first trimester. And finally, I add an anatomic factor, which is usually in the second trimester, but sometimes a large submucous fibroid or Asherman syndrome, which may be iatrogenic or tuberculosis induced, can also give rise to first trimester pregnancy losses, recurrent.
What about the torch infections, madam? That is quite common, no? I mean, we see very often torch profile also being done for patients with RPL. So is there any relevance?
No. Nowadays, there is no relevance for torch profile, and it should not be a part of even the investigations of causes for RPLs. So even now, a lot of obstetricians are misled, and they do the torch profile, and they have difficulty in interpreting it and end up treating the patients unnecessarily. So I wish to say that the torch profile is not included in the RPLs, and neither is the heritable or inherited thrombophilias are included in this, unless the patient has a very significant family history or a personal history of thrombosis.
And what about they here with the first pregnancy, they had a neural tube defect? I mean, do you think that is related to the miscarriage, or could it be an unrelated sporadic
neural tube defect is a birth defect? Yes, it has, because once the woman has a neural tube defect, there is 2 to 5% chances of recurrence, and this is like 25 to 50 times more the risk from a general population. And also, if the patient has had 2 or more NTDs, the chances are around 10%. So it is related, though it is a preventable neural tube defect, and it can be prevented by giving high doses of folic acid periconceptionally, starting 3 months before to until 12 weeks. And previously we were giving, and some of the high risk factors like twins, multiple pregnancies, people on anticonvulsants, they are all at more risk. So these risk factors can be identified, and they can be prevented probably by giving a periconceptional folate. Previously, we would give 4 to 5 milligrams. Nowadays, they say any dose more than 1 milligram is not going to help because it's not going to absorb. So in a way, it is related to an RPL because the patient carries an increased risk each time she has an NTD.
But here, I think the next 2 pregnancies were very early losses. So I don't think probably in this family, this was related. But as you mentioned,
here
there is a risk.
Here it's not related, but in general, we do need to think about it, though it's preventable.
Right. Yeah, so I think this case did undergo most of these tests, what you have suggested. So Dr. Valli, please tell us about
Yes.
the reports of this patient.
Sure, ma'am. So workup for the couple was done. Wife's workup, like mainly for non-genetic causes. APLA workup, including anticardiolipin, antibody IgG and IgM was negative. Anti-beta-2 glycoprotein antibody IgG, IgGM was were negative. Lupus anticoagulant was negative. Thyroid function tests were normal. Prolactin levels were normal. HbA1c was also normal, which was 4.5%. And yes, genetic.
Yeah, I
So,
think
Dr.
that would,
Shagun, what
yeah.
genetic workup would you recommend in this case? Because all
So
these
now
are
that
normal.
Yeah, so we've ruled out most of the things, and of course, by history, all the other lifestyle factors also. So most of those, I mean, this couple did not really have anything else significant. So now this, I mean, comes, kind of, a point where now we are looking at more rarer things. So as whatever the acquired factors are mentioned, so most of the patients we would get an answer. I mean, those would be the commoner causes, but still, in a proportion of cases, there would be a genetic factor which would be underlying this RPL. So in fact, Dr. Valli, just press enter. So in
Yes.
fact, 2 to 5% of couples who are having these first trimester recurrent pregnancy losses. So in fact, the etiology is in one of the partner, and this particular partner has a rearrangement, what we call in the chromosomes. So which gives rise to abnormal gametes when this person tries to reproduce. Next. So that is something then we kind of always do. So in fact, we do it in parallel with the acquired factors, because sometimes we have seen families where both things can be there. So a family could be having a genetic factor plus an acquired etiology also. So it's always best to do a comprehensive workup for every case. And I think Madam had already mentioned, Dr. Meera, that inherited thrombophilia workup is not to be done as a routine first tier test unless there is something significant in the history. So history as in, so if there is history of any thrombophilic event in the patient herself or in the family member, or there is history of, let's say, a later pregnancy loss with a documented uteroplacental insufficiency with no cause for it, I mean no maternal or etiology, no other acquired cause for it, then probably in absence of any other cause we may consider an inherited thrombophilia workup, but definitely not as a first tier test for a couple presenting with a first trimester RPL. So now in this case, I think what next, I think the testing was done. So Dr. Velli will tell us about that. So
Yes, ma'am. Couple karyotyping was done. Husband's karyotype was normal, male karyotype 46XY. And the wife's karyotype revealed 46X6, T510. So this I'll break it down. 46 is the total number of chromosomes. 46, X6, female sex chromosomes, and T510 here. So let's see the fifth chromosome. When we compare it with the other chromosome, which is the normal one, here we see some extra, something additional and some, translocation which has happened. And here in the 10th chromosome, we can see the Q arm of 10th chromosome and the P arm of 5th chromosome. They have been rearranged, they have been translocated. However, the total number of chromosomes, it remains the same, which is 46. Therefore, it is a balanced kind of a rearrangement or a balanced translocation. And therefore, the wife is a balanced translocation carrier. And usually the balanced, those who have balanced rearrangements are phenotypically normal. They hardly even come to any clinical attention. And usually they have, they may or may not have these kind of reproductive issues. They can also have normal offspring, but they sometimes face issues like infertility, early pregnancy losses, or anomalous fetuses and all that. These kind of...
we need to mute Jayanthi madam, I think her background. Yes.
Yeah. So these kind of reproductive issues can happen in an individual who is a carrier for balanced rearrangement. So reciprocal translocations, it's the exchange of material between two non-homologous chromosomes, like what we saw in the previous example, between 5th and the 10th chromosome. The prevalence of translocation is 1 in 625. And like I told, balanced carriers are usually phenotypically normal. They hardly even come to any clinical attention otherwise. Reproductive consequences, they happen because of the behavior at meiosis, which I'll be explaining. And similar to reciprocal translocations, there can be other familial balanced rearrangements such as Robertsonian translocations when it is going to involve two acrocentric chromosomes. Then inversions like pericentric or paracentric inversions, they can also result in some reproductive issues like adverse pregnancy outcomes. So familial rearrangements, these kind of translocations, they can pass through multiple generations of a family member without even detection. When these families are ascertained, there is usually the result of, usually because of the reproductive issues that they face, they come to the clinic. So it can be presence of, there can be infertility, there can be spontaneous first trimester losses, there can be anomalous fetuses, or even after the baby is born, there can be some developmental delay or intellectual disability. Like in this family also, we saw that the wife's sister, she also had primary infertility. Though she was not tested, maybe she is also a carrier for the same translocation. So unless a family is large and accurate information is obtained, it's very difficult to assess or the empiric data unless we test the individuals and complete family history is available. It's not possible to assess the exact risk and exact risk values. So here I would just like to tell how they segregate the chromosomes, how they segregate during meiosis. So this image just shows the normal segregation pattern. This is like one set from the father, one from the mother, one set from the mother. And we can see that the bivalent formation happens between homologous chromosomes, exchange of material and all happens. And then when they go through meiosis 1 and meiosis 2, we finally have haploid cells, only 4 haploid cells. So what happens, this is a normal segregation pattern, but what happens if there is a translocation? Excuse me. So here I have just shown an example, like there is a translocation between chromosome 11 and chromosome 22. So we can see that a part of 22 has come to chromosome 11 and a part of chromosome 11 has gone to chromosome 22. So what happens during segregation? They try to align together, they pair up with the homologous chromosomes and they form something called quadrivalent when there is a translocation. So it can be adjacent or alternate. So what happens if it's an alternate pairing? So for example, we see ABCD. Here, what happens if A pairs with D or B pairs with C? So here, if A pairs with D, here we have one normal A, D, that is in the example, chromosome 11 and chromosome 22, which is normal. Suppose if B pairs with C, here we see this is like a balanced carrier because they have both the chromosome material has been rearranged. Otherwise, they are going to be balanced carriers just like the parents. But what happens if the adjacent pairing happens, like A pairs with C or B pairs with D? So here we see either if A pairs with C or if B pairs with D, we see there is some imbalance, like there is some extra material of this 11th chromosome which has gone to 22 and a part of 22 has been lost. In this scenario, a part of extra 22 chromosome material has come and a part of 11 has been lost. Both are unbalanced. So this can result in partial trisomy or partial monosomy. Like in the first case, it is partial trisomy 11, partial monosomy 22. The other case, it is partial monosomy 11, partial trisomy 22. So this will happen in adjacent pairing. So as a result, there are some 16 possible gametes. Many of them can be non-viable. Like monosomy, most of these monosomies and trisomies may be non-viable. Like some, except for this common trisomies, which can continue till term. Some of these monosomies, they are very extremely lethal that even before the pregnant lady realizes, or even if she gets to know that she's pregnant, it can, she can, there can be implantation failure and they can present as subfertility also. And some of these gametes can have balanced chromosomal complement. And then if there is any imbalance, then there is a spectrum of phenotype which can happen, which can vary from a failed implantation, occult abortion, then first trimester losses, late pregnancy losses, or viable abnormal life born child. So these are all different possible outcomes when there is a imbalance.
So, Dr. Shagun, now may I ask you, now that you know the history and the genetic, this thing has been explained in detail, what are the reproductive options for this couple? Should they plan for a spontaneous pregnancy, then go for prenatal testing, or should they go for IVF FIGO with PGD, or should they borrow the gamete, or should they go for adoption? I mean, these are the options. Which would you prefer, and what is your priority?
So, see, one of the, I mean, this is a kind of a misconception, when somebody comes across this couple, I mean, where one of the partner has this kind of chromosomal rearrangement. So, many people assume that once these kind of chromosomal rearrangements are there, this couple cannot have a normal baby. Okay, so that's I mean, it's a myth or it's a misconception. So, as Dr. Valli had shown, so there is there are different types of gametes which form, and two of those gametes are completely normal gametes. They will be either like the parent, a balanced translocation carrier, or they will not even have the translocation. And in fact, nature is so beautiful that it always favors these natural gametes. So out of 16, 2 are normal and 14 are abnormal. But in fact, I mean, in reality, what happens is that the normal ones are likely to happen more. So in fact, 50 to 60% of the gametes which are going to form and the babies which this couple will conceive naturally without doing anything, without even going to a doctor, are going to be normal. Okay, they will lead to go through a normal pregnancy, have a normal child even without us intervening. But of course, I mean, that being said, so Vali, you can go to the next slide. So
Yes.
what I said is that there is a 50 to 60% chance of a normal offspring, okay, without any medical intervention. But then, of course, there is a much increased rate of risk of miscarriage in this couple. So which is to the tune of 25 to 50%, 25 to 30%, as compared to, a person or a couple where these kind of rearrangements are not there. And then, of course, we also saw that there are other possibilities also which may happen if one of the abnormal gamete goes forward and forms a zygote. So next slide. So what is the option? Basically, option often is, whereby we are discussing these things with the couple. We explain them the risk of all this, and we also reiterate that there is a 50 to 60% chance that they can have a, they will not miscarry and they're likely to have a normal baby. So very often what the couple does depends on a lot of factors. It depends on, how many miscarriages they've had, how long they've been married, how anxious they are, what is the age of the couple. So all those factors also come into, bearing when the decisions are taken by a particular couple. So usually a younger couple, recently married, maybe had just 2 miscarriages, 3 miscarriages. I mean, personally, I encourage them to, try for a spontaneous conception. And then if the pregnancy doesn't get aborted, then we do a prenatal testing. So either we can do it by chorionic villus sampling at 11 to 13 weeks, or we can do it by amniocentesis at 16 weeks. And then we look at the chromosomes of the fetus. And most of the times the fetus, because it's not aborted, most of the times we expect it to come out to be normal. And then we confirm that, and then the couple can continue the pregnancy. So that is what would most of the times, I mean, for a younger couple, where we don't have much of still too much of morbidity happening, many of them do go ahead with that. But then if the other thing is
When
there,
would you recommend IVF FIGOs
yeah,
with the PGTs?
so
Under what
right.
circumstances?
So that's what, so, if they sometimes the couples are very distraught, very anxious, and that of course happens when they've had more, more miscarriages. So every time they end up with a miscarriage, unfortunately. So those situations, or, they married for too long and they're also having difficulties conceiving. So those couples, we do kind of, encourage them to go for an IVF and then go for a PGT SR. So PGT structural rearrangement SR, whereby now we can check the chromosomes of the embryo, the blastocyst, and the blastocysts which have a balanced chromosomal complement. Those only are basically transferred then, or are the ET is done for those. So that is, so for, again, it's very often a couple's decision actually. So medically speaking,
How do
it's
you
not.
justify? Can I just ask you one question?
Yes,
How do you
please, please.
justify the deleterious effect of the PGD itself on the embryo, and also the added cost? how would you counsel the patient regarding
See,
this?
again, so that's what. So again, as I mentioned in the beginning, most of the time it's the couple's choice. We tell them all these options. So, and then the options, of course, the cost also is a factor, right? I mean, when we tell them that these are the options, so if they have to go for an IVF with a PGT, of course, there'll be a huge cost factor involved. So that's why the decision is actually at the end of the day the couples, and not the doctors, or not mine, or not yours. Because there are so many factors they will be also considering, including their financial status. So there are many couples who are not able to afford IVF, so they do plan spontaneous pregnancies, and then they come back to us and we do prenatal, and many of them have had healthy babies subsequently. So it's not at all mandatory in any situation, in any circumstance. It's many of the options.
Is gamete donation another option, or is it the next alternate after this?
So again, the gamete
Is it a
donation,
parallel option?
yeah, I mean, it can be given sometimes, but again, it's not really indicated. But yes, for the cost factor. So, like, suppose they are okay, they're okay to go with IVF, but they don't want to go for PGT-SR. Again, as you mentioned, some embryo biopsy, some adverse effects are there, and additional cost comes because of PGT. So sometimes some couple may just go for an IVF with a donor, a gamete, and changing the gamete of the partner who has this particular chromosomal rearrangement. So all these are options which are there. Again, mostly the decision is given to them. I mean, it's taken by the couple. And in some cases, yeah, I mean, the PGT, as I've, mentioned here. So again, the other factor is also, I mean, very often, sometimes, if they go to an infertility clinic, they'll encourage them for, going for IVF, PGT, SR. But we forget to remember, that the live birth rate with the IVF, PGT is going to be 40%, whereas a live birth for this couple itself, a normal live birth is 50 to 60%, right? So it's comparable. Yes. So it's nowhere that it's to be done. I mean, definitely not. I mean, these are all options which some couples take due to various reasons, including financial, including personal, including other things. So, and then of course, I mean, as you mentioned, so because here this couple has a, previous neural tube defect. So we will also, here start with the folic acid. So high dose folic acid to be started 3 months pre-conception.
Yeah, but I just, the current literature says that not more than 1 mg is needed, because it says even if you go 4 to 5, it's not going to be absorbed. That is what the current literature says. I may be corrected if I'm wrong.
Okay, but do we have preparations? I mean, I don't know. Do we give them double dose of the 500 microgram in that case? Like practically,
yeah, 400 into 2. 500 into 2 or 400 into 2, yeah.
Into 2, okay.
Yeah, 800 is also sufficient.
Okay. Yeah. And of course, the other thing which we all advise for all the patients who come to us, and again, this is something we want to tell to all obstetric audience, that we need to do routine carrier screening for every couple who's planning a pregnancy, at least for thalassemia. That is bare minimum. It is available everywhere. Thalassemia major in India is as common or even commoner than Down syndrome. And we are doing screening for every pregnancy for Down syndrome, but we are not screening for thalassemia. Whereas thalassemia screening is cheaper than Down syndrome. So this is something which has to be done. It's easily available in most of the labs. And of course, we also recommend spinal muscular atrophy screening, but I understand, I mean, access to that is limited in most centers, but at least thalassemia screening we advise.
So the other question is, the RCOG recommends karyotyping on the products of conception, whereas the ASRM and the American College recommends parental karyotyping. So what's your this thing on that?
We'll come to that. I think I'll ask Dr. Valli to show this case couple story, and then we'll discuss this.
Yes. So with that counseling, the couple had opted for spontaneous conception and prenatal testing. So then they came back during their 4th pregnancy at around 14 weeks. And during this time, antenatal scan revealed holoprosencephaly with complex cardiac anomaly with cleft lip, like a multiple malformation. And in view of these findings, the pregnancy was terminated and the POC sample was sent for karyotyping. So this is just to show that the pregnancy was terminated at 14 weeks. And this is the karyotype of the abortus. So here we can see that some rearrangement, which is an unbalanced rearrangement that has happened between the 5th and the 10th chromosome. So like I already described how they segregate and all. So there can be some imbalances where a part of one chromosome is lost and a part of the other chromosome involved is duplicated. So something like that has happened in this abortus, and that the resultant thing is partial monosomy 5p and partial trisomy 10q. Further, for confirmation, we did chromosomal microarray on the POC. So chromosomal microarray, as we know, it is a molecular cytogenetic technique which has a much higher resolution compared to conventional karyotyping. So here we use this oligo SNP. In most of the labs, they use this combined probe, oligo probes and SNP based probes. And here the report came as 5p15.33, p15.2. So here this is the breakpoint, exact breakpoint involving the 5th chromosome where the rearrangement has happened, and the coordinate also we get. So the karyotype, the whatever report we got in karyotype has been confirmed through chromosomal microarray, indicating partial monosomy 5p and partial trisomy 10q.
So I think I'll come back to the question which, Dr. Meera had asked. So RCOG in the 2023 recommendations actually says that we should be doing a POC chromosomal microarray instead of doing a couple karyotype as a first tire test, whereas ASRM and I think even ACOG advises that the couple karyotype should be the first tire test. So there is lot of, kind of not really a controversy. It actually comes back to the same point, but there is a lot of confusion regarding this. So actually what we need to understand is that whenever there is a first trimester miscarriage, more than 50% of these miscarriages will have a chromosomal abnormality. So even if there is a single miscarriage happening, if you do a karyotype or a microarray of that POC, you will find in some chromosome problem in 50%. But majority of these are just sporadic. There are sporadic abnormalities which don't happen again. So these are not the cause of recurrent miscarriages. When we are seeing recurrent miscarriages in a couple, then the cause lies in the one of the partner in the form of these balanced rearrangements. So again, you can pick up even this by doing the POC microarray. If I do a POC microarray for a miscarriage, so I can pick up even the sporadic problems. I can even pick up these parental rearrangements. But the main difference is the cost. So chromosomal microarray on the POC costs somewhere around 15,000. Whereas karyotype of the couple will cost 1,500. Okay, for one partner. So there is a 10 times cost difference which we are looking at here, 5 times if we think both partners, of course, we have to do. So whereas the RPL will be explained through parental karyotype. So even RCOG says that if you find in the POC microarray something like what Dr. Valli just showed, unbalanced kind of rearrangement, then go back and do the parent karyotype. Okay, so it revolves down to the same point that actually the cause of RPL will be found in the parent's karyotype, and microarray of the POC may help you. And why RCOG is saying, because that is the first test, because for some country like UK, doing a microarray in today's date is cheaper than doing a karyotype, because they have no problem of machinery or reagents or lab. They have problem of manpower, trained people. And for us, for India as a country, we know that we are, our power is our manpower, literally. So we don't have any dearth of trained people. We have, of course, financial constraints, and we don't have microarray so easily available. So it's going to be very costly for us. So it makes sense for us to do karyotype. What, good old guidelines like ASRM way back in 2012 has said, and not change its stand. That's to do a couple karyotype. That's the simplest test that will explain your RPL, and which will then, we can further intervene on that.
I have in my clinical practice experienced a lot of problems with the POC karyotype. Most of the times I get a report saying there is no culture, something is contaminated.
Yes.
So I prefer to do a parental karyotyping straight away. Is that correct?
Yes, yes. So for RPL, that's the right approach. But if suppose sometimes some couple wants to do a POC testing because the for couples even a single loss is important, so they want to know why it happened. So then we can do POC testing, but then we do a microarray because don't do a karyotype because that's going to fail most of the times. So then
microarray on the POC is preferable to doing karyotype.
karyotype of
Why
the
don't we do
POC.
a microarray in the parents? What is the problem?
Yeah, so then again this microarray is something which is a chip-based test. So it does not give us a picture of the karyotype. We can't see the actual karyotypes or the chromosomes of that person. So it will only show an abnormality if there is a loss or gain of chromosome segment or if there is an imbalance. Whereas in this couple where we are expecting that they have a balanced rearrangement, so there is a translocation, but their DNA is all there. All the chromosomes are there. Only they are rearranged or shuffled some parts. So microarray will not pick this up. Microarray only tells us imbalance. Karyotype only tells us how the chromosomes are arranged. So it also tells us balance things. So for a couple, we don't expect them to have a imbalance. So that's why karyotype is the test of choice for a couple. We should never do a microarray of the couple. It is not going to give you anything. It's going to come normal actually.
Okay.
So go to the next slide. So this is something which I just said. So because of the cost and the rationale behind it, it's a karyotype which should be done. So a karyotype of the couple. Next slide. So and then of course as madam, you were saying, so if suppose we want to do POC testing for whatever reason, then microarray is the test of choice. And sometimes we do advise POC microarray in patients whose RPL remains unexplained. So suppose we did everything and even the couple karyotype is normal, there is no acquired etiology, then in some cases we do tell to do POC microarray to look for some cryptic rearrangements which are missed on karyotype. So those are some things which still, I mean, there is a role for this still at a particular, in the diagnostic algorithm. But it is much down the lane and not as a first test. So next slide. So then, I mean, just to summarize, so madam, any other questions, I mean, which probably you may want to discuss here? Dr.
No,
Meera?
I think an elaborate discussion on the genetic workup has been done. I think that was very informative. And I did brief on the few other tests that we do for non-genetic causes in the first trimester.
So then, so from the genetic point of view, so what we see is that we basically need to do karyotype of the both partners, and the inherited thrombophilia is definitely not a first test. It is only for a specific situation if there is a history of thromboembolism in the patient or family members or an unexplained.
I would also add to that there is no point in doing the acquired thrombophilic tests, which are the specific antibodies immediately. You should wait for at least 6 weeks after the miscarriage. And most of the times the tests are not repeated. You should repeat them after 12 weeks for confirmation. So I wish to reiterate on this point because most of the times these two guidelines are not followed and we may end up not getting accurate results or creating anxiety in us as well as in the patients.
Yes, ma'am, absolutely. And ma'am, the other thing which I also have seen is that very often the correct antibodies are not tested by many of the labs. So they just do some antiphospholipid antibody, which we don't know what all it contains. So we really need to do the 3 tests which were mentioned. So anticardiolipin, beta-2 glycoprotein, and lupus anticoagulant. And as you said, 6 weeks after the last miscarriage, and to be repeated twice, 12 weeks apart.
Twice, yeah.
So I think with this, we'll end this particular case. So, oh yes, so I think this is another one question which sometimes gets asked from us geneticists that, why do we even want to do this test and all, like what is the relevance? Anyway, patient will have a normal baby 50 to 60% of the time. So one of the reasons which is again, very important, which just to reiterate that, it is also to prevent the birth of a child with a neurodevelopmental disorder. That's why we are doing prenatal testing in the ones who carry beyond first trimester, because this is another outcome which can happen in this couple. So we should not miss testing this couple. And of course, the other things we have discussed. So I will, Dr. Wali, we can stop here, I think.
Thank you, ma'am.
So the questions we will take in the end, I think. The Q&A session. So Dr. Monica, do you want to introduce the next? So thank you, Dr. Meera. Thank you for joining.
Thank you very much. I really enjoyed the interesting session. And I did get a few knowledgeable points, which I will put it into my practice. So
thank you so much. So
Thank you,
Dr.
faculty
Monica,
members
yes,
and
please.
presenter. Moving on to the second session, couple with second trimester mishaps. So we are going to address a complex scenario, and I'm pleased to welcome our faculty members, Dr. Shagun Aggarwal, and joining her is Dr. Padmaja Alani. Dr. Padmaja Alani is a professor, OBGYN, MGMH, and Usmania Medical College, and senior consultant at St. Teresa Hospital. With MD, DGO, and FICOG and over 35 years of clinical experience, she has held key leadership roles in OGSH and is widely known for her work in high-risk pregnancy and safe motherhood. The case now is going to be presented by Dr. Pratyusha Koneru, Medical Genetics Resident, Department of Medical Genetics, Nizam Institute of Medical Sciences. Over to you, Dr. Pratyusha. Thank you.
Okay, ma'am. My patient is Mrs. P, who's a 28-year-old female with G3, P2, D1, and A1 at 8 weeks of gestation, who's married consanguineously, and all her previous pregnancies were also spontaneous conception. So her first pregnancy showed a TIFA scan with dilated lateral ventricles, with left measuring 11 mm and right 10 mm, with improperly visualized CSP and colpocephaly. And there was also echogenic bowel loops, for which this pregnancy was terminated at about 7 months of gestation. And her second pregnancy, her NT scan was normal, and her growth scan at 24 weeks showed fetal growth restriction with oligohydramnios, echogenic bowel, and the umbilical artery Doppler showed absent end-diastolic flow. Her growth scan, again repeated at 30 weeks, showed intrauterine fetal demise. And her third pregnancy, during which she had presented to us, showed an early scan at 6 weeks with monochorionic diamniotic twins, and she had a missed abortion at about 8 weeks of gestation. There is also history of weakness of right upper limb and lower limb with severe headache in the mother right after the delivery in the second pregnancy, and her MRI brain showed CSVT, and it was assumed to be likely due to postpartum cause, and she was started on anticoagulation at that time. So this is the pedigree of the couple, the family. The marriage line is shown as a double line, which indicates the consanguinity, and each of the color shaded indicates a different phenotype or presentation. So
I think now, Dr. Padmaja, so now that we have this couple, so they've had somewhat different mishaps, but at least, twice in the second trimester, we see that once the baby had something on scan, next baby ended up being an FGR and IUD. So, and then again, of course, she also has a missed abortion. So now in this couple, and also we are looking at the history of CSVT for her. So, what kind of workup or what kind of etiologies would come to your mind, and what would you want to do this patient?
In this couple, actually fetal anomalies are there, and in the third pregnancy there is also miscarriage, and consanguinity history is also there. And in the second pregnancy, because there is history of oligohydramnias and FGR and DVT in the postpartum period. So this history brings two things into my mind. One is the APLA syndrome, and that is in thrombophilias, and other is the genetic, most probably because of consanguinity and anomalous fetus. Miscarriage in the first trimester also may be the reason. Genetic causes may be the reason. So first, before going to the genetic causes, I would like to see the common causes. Basically, as Dr. Meera said, in the first trimester losses, we have to rule out even the endocrine causes, which are also, which may be one of the causes for second trimester miscarriage also, like diabetes, hypothyroidism. And of course, the other causes like cervical incompetence, uterine anomaly, all those, they have a different history from which we can actually make out. And so here, basically, first thing I would look is into the APLA, serology, testing for APLA syndrome. And then if that is normal, other investigations are normal, we should go for genetic testing.
So what about torch, madam, here? Like in the sense that one baby had ventriculomegaly.
Yeah. As torch, again, as Dr. Meera said, it is usually not a cause for RPL, but second trimester losses sometimes maybe because of infections like CME infections and parvovirus, but mostly they are sporadic rather than recurrent losses. So in recurrent losses, of course, if it is sporadic, again, we are not going to do for torch again in the next pregnancy. And recurrent, it doesn't have a role. I think in RPL, there is no role for torch testing.
Because mostly the patient, after one infection, they develop immunity. So there is the infection happening again and causing another pregnancy mishap is very much unlikely.
And most of these, even if you do, they'll be IgG positive rather than IgM, which is more, indicates active infection or recent infection, IgM testing.
IgM.
Of them,
So
IgG, which is
IgG.
previous infection, which doesn't need any treatment right now. Okay.
So I think Dr. Pratyusha, then let's see what this case, what was the APLA profile. So that's what Madam has advised. So let's go on with the case.
So all these investigations like APLA profile, thyroid, blood sugars, and even homocysteine level are all within normal limits. So next option would be genetic testing, mostly because there is also history of consanguinity. Better do genetic testing. Okay.
So here I think, yes. So yes, so as madam you were saying, so we need to now think about genetic testing. So this particular scenario, no, it's a little bit different now for the what we saw in the first scenario. So first, no, we saw that the scenario of a first trimester loss. So first trimester loss, I mean, there is nothing much for us to see as such in the morphology of the conceptus. But now here, this family has 2 second trimester losses relatively late in pregnancy. So actually here, as geneticists, we want to gather more information about those fetuses. So, so what we do usually is that we will really literally dig into, families, all records. We ask them to take out their all the single papers. We also ask them to send if some photo is there at home by WhatsApp, if some file is there. So literally every single thing, whatever evidence, whatever information we can gather about those 2 fetuses of the second trimester, that we gather as geneticists, because in second trimester losses very often, so as you mentioned, so the consanguinity is an important factor, especially in this couple. So very often many of these second trimester losses, they can be due to chromosomal abnormalities, but then they can also be due to certain single gene disorders, which are basically autosomal recessive, and they are there because they occur because of the consanguinity of the couple. And many of such single gene disorders, there will be specific features in the baby. So those features we now want to look by looking at the ultrasound reports, by looking at even the images in the ultrasound. And then luckily, if some family has taken photo of the abortus after delivery, so then we tell them to show those photographs, because there are so many clues which we get by just looking at the photo of the baby. And this helps us in understanding kind of what disease probably that, or what genetic disease that baby has. So what is the test which we should do for that baby? So those kind of clues we get. So this information gathering is a very important step before jumping to the genetic test, because there are so many genetic tests which are available, and it is very, and they're all costly also. So we need to be sure that we know what diagnosis or what differential diagnosis we are thinking, and accordingly we decide the test. And for that we gather all this information. So Dr. Pratyusha, then in this case, then what other information then you were able to elicit?
So we were able to get the fetal photographs. This is the photograph of the first fetus from the first pregnancy. It was a male fetus, and there was some facial dysmorphism that was noted. There was sloping forehead, prominent beaked nose, overhanging lip, and long philtrum. And the ears were also kind of low set and posteriorly rotated. And there was microretrognathia also. And in the lower limbs, as we can see, the great toe or the hallux was rudimentary on both the sides, and there was some other toe reduction defects also. And we were not able to assess the hands in this photograph, unfortunately. And this is the photograph from the second fetus of the second pregnancy. This was a female fetus, and this fetus also had facial dysmorphism with prominent nose and long philtrum. There was infraorbital creases and increased facial hair. The upper limbs appeared normal, but the lower limbs, again, we were not able to see. This was the only photograph. And both the fetuses, other than the photographs, evaluation in the form of autopsy was not done, and there were no stored DNA samples also, no cord blood or cord tissue samples for genetic testing.
So are they connected to the same etiology, or I mean, if at all you want to do genetic testing, what tests are available?
So now, I mean, like, looking at these two babies, I mean, the first baby, we are kind of quite at this point almost sure that the baby had a genetic disease, because we are seeing significant dysmorphism, and we are seeing all these digital abnormalities, which we call as limb reduction defects. So there are a few, just a handful of genetic conditions where these kind of limb reduction defects are there. So we have already started thinking that baby could be having one of those syndromes, which are all basically due autosomal recessive due to the parental consanguinity. The second baby, unfortunately, and in the sense that we are not able to see the lower limbs, so it's difficult to say whether it's the same thing or not. But the face of the second baby also looks somewhat dysmorphic and similar to the first baby. So it's possible that they are both same. But then again, of course, in the second baby, there were no scan abnormalities. First baby, there was some ventriculomegaly, colpocephaly reported. So, I mean, the second baby's phenotype was a little bit FGR and a little different. So at this point, it's very difficult to actually really conclude that they are both same. There are some similarities and some differences, and the first baby definitely seems to have some genetic condition. Second baby may or may not be having a genetic condition. That's what I would infer at this point. But unfortunately, as Pratyusha mentioned, so we don't have samples. So again, it's very important, I mean, for the younger audience who are there, that I mean, these photos helped us a lot in this case. Actually, we'll see how they helped in solving the case. But these kind of photographic evidence, and then collecting samples. So in our state, there is this practice of keeping the cord segments of babies. So those cord segments of babies are kind of lifesavers often for these families, because from that segment also we can take out DNA of the baby. So if they have that segment, even if it is dried, even if it is kept in the room temperature anywhere, if they have that, we can extract the DNA of the baby and do genetic test. This couple, of course, did not have any, because they were abortuses, of course, they are thrown. But I mean, if that is there, so I mean, we should make a practice in such cases to take photographs, to store sample of the baby, even if the couple don't want to do anything at that point of time. Later, they will want to do when they want to plan a pregnancy. So, but here, of course, it was not there. So what we do in this situation is that we advise now again for the testing of the parents only. And here, of course, besides the chromosome test, we will also, because now we are thinking of couple consanguinity, autosomal recessive disorder, especially in the first baby. So we will do sequencing for the couple. And one test nowadays, I mean, the new technology is now available called as next generation sequencing, which we used to do a test called as exome sequencing. So that test can actually help us in looking at the mutations in the couple, what all mutations they are carrying, and which then we can correlate with the baby's phenotype. So that's how we move forward here. So I think Dr. Pratyusha, you'll tell us what were the results for this couple.
Yes, ma'am. So we had ordered a couple karyotype, which were both reported to be normal for the wife and husband. And because the acquired thrombophilic workup through APLA was negative, there was also history of CSVT in the mother. We had ordered testing for inherited thrombophilias through protein C, protein S, and antithrombin 3 assay, which were normal. And also rarely for factor 5, factor 2 laden mutation, and MTHFR mutation was also negative. So then the couple carrier screening was done through exome sequencing in both the partners. This revealed multiple variants in a couple of genes. So both wife and husband were heterozygous for likely pathogenic variant in DOX6 gene, which is related to autosomal recessive Adams-Oliver syndrome. And the husband was heterozygous for likely pathogenic variants in 3 genes, PCNT, QDPR, and FKTN. 3 of them are related to autosomal recessive phenotypes. And the wife is heterozygous for a mutation, likely pathogenic mutation in PROC3 gene, C gene, and husband does not have the variant. And this thrombophilia 3 is associated with both autosomal recessive and dominant phenotypes.
So briefly, I think I mentioned.
Yeah, about exome sequencing, you have already mentioned. And
so now, like in this scenario, no, ma'am, very often like these kind of reports come to obstetrician nowadays. Patients are getting it done, and they, they go to labs, they do these reports, and they come, to the clinician, and then there are so many things there. So, like, what do all these kind of things mean? How do we interpret all these kind of reports? So in this case, of course, no, the photographs, as I mentioned, of the first baby were really helpful. So let's go to next slide, Dr. Pratyusha. So the first thing what we found actually was this mutation, which was there in both the partners. And that means that heterozygous means that they are, so all of us have 2 copies of every gene in our body. So if one is mutated, that means heterozygous. If both are mutated, that means homozygous. So for autosomal recessive diseases, both copies have to be mutated. That is, patient has to be homozygous, then only patient develops disease. Whereas heterozygous person will be a carrier but will not manifest or not have the disease because they have a normal copy also. So what we found is that both husband and wife are heterozygous carrier of this mutation. And this is likely pathogenic, that is, it is likely to be disease causing. And what will happen is that this couple, if they both of them transmit this mutation to their baby, then their baby develops this disease, which is called as Adams-Oliver syndrome. And this is, as we mentioned, autosomal recessive. And these are the features. So they have sometimes some punched lesion on the scalp, which this baby we could not assess. And they have limb reduction defect, similar to what we saw. And they can have CNS abnormality, like the ventricular dilatation, which was there in this first baby, and some dysmorphism, which was also there in that first baby, and some oligohydramnios also, which is actually there in the second baby. So at least for the first baby, we are assured that this was the disease that that baby was having. Of course, ideally, we would have wanted to do the test for that baby and confirm it, but in most likelihood, that baby had Adams-Oliver syndrome, the first baby. Both parents are carrier, and then that's how that particular baby ended up being affected. Second baby, we are still not sure because we could not see the lower limbs. So this is the main mutation which we have found through doing the testing of the couple. So we'll go to next slide. Then let's see for the other things. So then there is one more mutation which the wife had. So this is in this gene, PROC gene. So this actually has an interesting thing. It can be autosomal recessive also, sometimes autosomal dominant also. And autosomal dominant means that even one mutation will cause disease. So heterozygous will also cause disease. And the disease is protein C deficiency associated thrombophilia. So what we are thinking is that this is the likely cause of the CSVT in this lady, and that's what probably contributed to the FGR also in the second pregnancy. And although we did do protein C level, we repeated it twice and they were normal, but there are certain mutations which cause qualitative defects and not quantitative defects. So the levels may be normal, but still the protein may not be actually functional. So because there is no other cause of the thrombophilia picture in this lady. So this is what we have we think is the cause. Of course, and we can't be 100% sure, but we think that this is what led to the CSVT and the second pregnancy FGR-IUD component. And besides this, there are so many other mutations which we are finding, but they are only in one partner. So one partner being carrier of an autosomal recessive disease, other partner not being carrier, does not cause any risk to their baby. So we can disregard those variants in most scenarios. Of course, there are some rare other situations, but that's outside the purview of this discussion. So mostly we can disregard those kind of variants.
Yeah, one thing what I have, when they went through the literature, what I saw is recent American Rheumatology, American College Rheumatology Society, they said APLA in APS criteria, this is 2023 criteria. Actually, the APLA may become positive within 3 years of clinical manifestation. So initially it may be negative, but once they have the CVST and all, later on it may be manifest as positive. So is one thing I just wanted to tell.
So that means that suspicion still remains, that means, for this patient, because this is, I am not aware of this. Okay.
Also, we need to check again later.
Okay. Okay. Right. Okay. So let's see then. So this patient then, what did we infer finally, Dr. Pratyusha?
Ma'am, so we concluded that the possible cause for the abnormalities in the first pregnancy is DOG6 gene-related Adams-Oliver syndrome, and possibly for the second fetus also considering the facial dysmorphism. And protein C deficiency variant, likely pathogenic variant, was found in the mother. And there, in the second pregnancy, there was FGR leading to IUD, resulting in IUD 30 weeks of gestation. And also after termination, there was CSVT. So this may also explain the spontaneous abortion in the third, pregnancy loss in the third pregnancy. So we had counseled the couple regarding the autosomal recessive pattern of inheritance. Like we had said, in the picture here, this is the representation of the parental alleles, where there are two alleles, the white one being the normal allele and the pink one is the mutant allele. So when that ghost segregation happens to the gametes, only one allele would go to each gamete, and then during fertilization, there is a possibility that there is 25% chance for each conception having the disease and 75% chance where the fetus is normal. So we advise prenatal diagnostic testing in each pregnancy. And for the inherited thrombophilia in the mother, this was managed with low molecular weight heparin in therapeutic doses and aspirin in consultation with the hematologist. So the couple had come back to us in their fourth pregnancy at 8 weeks of gestation, and they were already started on aspirin along with the heparin. And we had advised them to come for a CVS procedure in view of the DOG6 gene-related carrier status in both the partners. The anti-scan was normal, and but then we were not able to do the CVS because the placenta was inaccessible, and we had called them back again for amniocentesis at 16 weeks gestation. So the heparin was stopped 1 day prior, and the early TFR was normal. It did not show any limb reduction defects. This is the face, and these are the feet of the fetus, and this is the hand. And we did not find any obvious defects. And the amniocentesis reports had come back. The maternal cell contamination was ruled out, and the QF-PCR for common chromosomal anomalies was normal. And as expected, because there was no scan abnormalities also, the DOG6 gene target variant tested came out to be heterozygous, which means the fetus is likely to be a carrier and not likely to be affected with this syndrome.
So then, so for this particular case, basically, some of the important takeaways, I mentioned also in between that we should remember to take photographs. So whenever there is an unexplained pregnancy loss beyond 12 weeks, ideal is to do an autopsy and to do a genetic workup. So even a single second trimester loss, which is unexplained, so it is not fitting into the cervical incompetence, incompetence history wise, or it's not like significant maternal external condition causing the fetal loss. So unexplained, basically, even a single second trimester loss needs an investigation. Unlike first trimester losses where we wait for 2 to 3 miscarriages before we start investigating. So, and the investigation here is not just doing the genetic test. It should involve doing an autopsy and a comprehensive genetic workup. But of course, very often it's not possible. It's a very sensitive issue, and many families don't opt for an autopsy. So at least at the delivery point, the obstetrician should make an effort to take photographs of such babies, and at least do a cord. The cord segment can be handed over to the family only for storing for later use, or we can even bank it with any lab for hardly 500 rupees, because these will later on, when they want to plan another pregnancy, then these are the things which will help us in doing further workup. But of course, sometimes when the baby's sample is not available, as was here, so we can try to pinpoint the cause, genetic cause, through the couple testing also, but this is not always successful. So that's also important. That's why the baby's testing is the most important thing. And then, of course, sometimes, and usually, as we saw here, that there can be multiple causes also in the same family, and some of these inherited thrombophilias can mimic the APLS kind of a presentation. So that also we should just keep in mind, again, depending on case-to-case basis. And most importantly, and these kind of workups should be done pre-conception, and not when the lady is already like 20 weeks pregnant, and then they are directly sometimes sent for a amniocentesis without making a diagnosis of what happened previously. So these kind of couples should come before planning a pregnancy. As a geneticist, I would want to see them before they go on to plan a pregnancy.
Yeah, preconception counseling is best actually.
So
I think,
any other final words from you, ma'am?
Yeah, that was a very informative and excellent discussion, Dr. Shagun. I think we need to, whatever, even if it is a single loss, as you said, even if it is a congenital anomalous baby which was detected in the scan, maybe we, as you said, you should have some photographs and preserved, which will help in further pregnancies, guide in further pregnancies. So it was very nice, and thank you, Dr. Shagun, and OGSH and all for involving me as a faculty in this, as a panelist in this program. Thank you so much.
Thank you.
Discussion is going very, it's very informative, both first trimester, second trimester. So many doubts general obstetricians will be having. So I think these sessions will clear their doubts, and we maybe will be more helpful to the patients later. Thank you.
Thank you. So, Monica, we want to take a short break here. And
sure, ma'am. Thank you to the presenters and the speaker and faculty members. So, ma'am, should I take the privilege of presenting about Unipath here? Yeah, thank you. So I'll precisely take 10 minutes of your time, faculty members and presenters. So should we take a break for 2 minutes and then rejoin for the session on genomic solutions for RPL?
Okay, I think, let's just, have a washroom break and a water break.
Sure.
Dr. Manjula?
No, I think Unipath can go on. Why should whoever wants to go on the water break can go? Let us do it uninterrupted, I think,
Sure.
is my opinion. Please go on.
Yeah, Monica, then I think you start.
Sure, ma'am. I would request Dr. Jayanthi to stop sharing. Thank you. Okay. So, good evening, presenters, faculty members, and the dear audience, clinicians. So it's my privilege to present in front of you about the precision genomic solutions that Unipath provides. I'm Dr. Monica Darji, General Manager for Scientific Marketing at Unipath and Unigenome. which is a genomic division of UNIPATH. So to brief you about UNIPATH, it is an NABL and ISO accredited lab with more than 16 years of experience in clinical diagnosis, with a menu of comprehensive services running up to 3,500 tests, 870 plus tests in the scope of NABL. We are guided by the expert leadership of Dr. Jwalant Shah, who is himself an MD hematopath, with a team of over 75 adjunct doctors, top-tier pathologists, and researchers. We have an extensive network of more than 50 laboratories conducting more than 15,000 tests each and every day. And we have a strong presence in more than 20 states and international markets as well. So we provide comprehensive solutions with various specialty divisions like biochemistry, hematopathology, flow cytometry, histopathology, immunohistochemistry, cytopathology, microbiology, molecular biology, and toxicology. Our curated division for genomics is Unigenome, where we perform all the genetic and cytogenetic tests. So we also would like to tell you that we have an experienced team, a faster turnaround time. We have 4 DM medical geneticists in our board, and we also offer pre and post-test genetic counseling, which is complementary to the patients by both certified genetic counselors. We also boast with a superior technology and state-of-art equipments which are installed in our national reference laboratory. We have a strong logistic presence which allows us to timely deliver the samples to our laboratory and give you reports as per the expected turnaround time. Moving on to some interesting panels that we have curated for clinicians like you is our first panel, that is RPL GenSight panel. It's an all-in-one genetic insight for recurrent pregnancy losses. So if a couple has come to you with multiple pregnancy losses, calling it a scenario of RPL, and you would like to investigate the product of conception along with a couple karyotyping to understand if there's a recurrence risk because parents are carriers of some balance translocations or some other etiologies, we can offer this panel. So we also offer maternal cell contamination check in this panel, for which we require 2 ml of maternal blood in EDTA. So we check if the sample that has been given to us, the tissue sample, actually belongs to the fetus, and then only we proceed with the chromosomal microarray test, giving you a precision diagnosis that can help you in taking clinical decisions. Moving on to the next panel, this is our RPL endocrine screening panel, where we combine the important tests for the endocrine evaluation, which was discussed during the webinar. So we combine TSH, thyroid antibodies, HbA1c, prolactin, PCOS markers, anti-Mullerian hormone, LH-FSH ratio, and progesterone as a panel to give you a detailed insight on the endocrine imbalances that a female might be facing, which may cause a recurrent pregnancy loss. Moving on to the next panel, our RPL immunological screening panel, which caters to the anti-phospholipid syndrome. So the tests that we perform are lupus anticoagulant, anti-cardiolipin antibody, anti-beta-2 glycoprotein. Along with that, we also offer you assessment of activated partial thromboplastin time and prothrombin time. So as discussed in the session also, this test should be offered to a pregnant a female who has experienced a pregnancy loss after 6 weeks of the miscarriage to get accurate results. And the workup, if it is positive in the first time, requires a repeat test after 12 weeks to confirm the diagnosis. Moving on to the next panel is the special panel of inherited thrombophilia only for indicated cases. So here we offer a factor 5 laden by PCR, PCR thrombin gene mutations, protein C, protein S, antithrombin 3, MTHFR by PCR, and homocysteine as well, to give you a complete analysis of the risks associated with inherited thrombophilias. Moving on to the next panel, We also understand recent literatures has shared that chronic endometritis and genital TB can also be a risk factor for recurrent pregnancy losses. So we have a curated panel called TRICE, which is a targeted RT-PCR for infectious chronic endometritis, which targets 13 pathogens in a comprehensive panel with real-time PCR. So it's actually detects the signature of a particular pathogen and accurately identifies if that pathogen is present or not. So the list of 13 pathogens is mentioned here, which includes the TB and NTM as well, along with some common pathogens like ureaplasma, mycoplasma, Neisseria gonorrhoeae, Enterococcus faecalis, and so on. We also have curated some add-on panels like TRICE panel with culture DST, which also gives you a clear picture of the drug sensitivity and drug resistance of that particular pathogen, which is detected. We also have IHC-based markers like CD138 and MUM1 marker, which gives you a very accurate diagnosis of chronic endometritis. We also offer midget culture for doing a TB culture with the AFB, acid-fat bacilli, for the acid-fat bacilli. So this gives you a very good clarity about the presence of TB pathogen, which can cause RPL. As well, we do TB by gene expert. Moving on to the next panel is the male factor for RPL. So we offer semen analysis as well as sperm DNA fragmentation test, which actually tells you the percentage of sperm that is damaged, and high DFI is a key biomarker for male factor RPL. Moving on to the next panel, as carrier screening is also being discussed, we have launched a new panel called Thalsma Carrier Screening, a simple female first test for two of the most common devastating genetic disorders. So with a female first approach, we wish to make this panel cost effective so that the acceptance and usability and an equitable approach can be taken to offer this to the patients. So for the thalassemia screening, we offer CBC and hemoglobin analysis by either HPLC or capillary electrophoresis. And we also offer SMA screening with the help of MLPA, because that's the gold standard and first line test for screening spinal muscular atrophy. So we offer a female first approach by which the workflow allows you to make it cost effective. And if the female screens negative, then there is no need of testing the father, because both of these conditions are autosomal recessive. And only if both the partners are carriers, there is a 25% risk that the fetus will be affected. So if the mother is identified a carrier, we proceed to the testing of the father for the specific condition which is detected. Either it can be a thalassemia or a SMA. Once we test the father, and if he is not a carrier, then we don't need to do any further analysis. If both the parents are carriers, then as mentioned, the reproductive risk is going to be 25% or 1 in 4 in every pregnancy. Therefore, we need to offer them proper genetic counseling and discuss the reproductive options. So this is recommended to be offered before conception, but during conception also this can be offered to a couple. And the timeline to do the testing is around 7 days. So as this test is available now and is a very cost-effective solution, but we need to also mention that this does not completely eliminate the residual risk of being a carrier for the disorders tested. And concurrent testing, which means testing both the partners, may reduce anxiety, shorten the turnaround time, and is particularly recommended in late pregnancies when the time is limited. For more comprehensive and equitable approach, we request the clinicians to opt for expanded carrier screening, entailing the next generation sequencing test as well, which is also recommended by ACOG and ACMG. So the hero product and the most curated product by us is an expedited precise diagnosis by rapid whole exome sequencing. So this is a backbone for several tests. Like when there's a fetus with dysmorphism, we do a rapid whole exome sequencing or a regular whole exome sequencing. It's also the backbone for expanded carrier screening for the couples. So we offer clinically actionable results with the platform Illumina NovaSeq X Plus. We also offer you AI-based variant prioritization, deep intronic variant detection, advanced variant calling with Dragon platform and pipeline, and superior database coverage. We have 4 clinical geneticists on our board who are available for discussions and for further guidance. The CNV pickup rate is more than 99%, which means we can detect minor copy number variations also spanning the exons. We also have 100% detection for and coverage for mitochondrial genome, which means that all the mitochondrial genes will also be covered for their SNVs, and more than 99% sensitivity for single nucleotide variants and indels. So with that, I would like to say that we are available, and I request you to reach out to our scientific team and the sales team for any further discussion. Thank you so much for this platform, and it is a privilege to associate with OGSH for this wonderful webinar series. Thank you.
So let's move on to the next session now. So Monica, would you like to invite our moderator?
Absolutely.
And the presenter also, of course. Monica, go ahead.
Yes, ma'am. I'm just sharing the screen.
Okay.
So moving on to the session 3, coupled with recurrent non-immune fetal hydrops, which focuses on recurrent non-immune fetal hydrops with a very interesting case study. I'm honored to introduce Dr. L. Fahmida Banu, Director, FemiCare Hospital, and a renowned minimally invasive surgeon, obstetrician, and gynecologist. With MD, DGO, DNBE, FRCOG, and FICOG, she has excelled in academia, publications, surgical training programs, and national CME initiatives such as FEMICON. She's also an active member and DNB trainer and the national faculty speaker. With Dr. Shagun ma'am, she's going to be the faculty for this particular session. So for this case to be presented, I invite Dr. Pratyusha Koneru, Medical Genetics Resident, NIMS. Over to you, Dr. Pratyusha.
So this family, my patient is Mrs. Q, who's a 25-year-old
Slides. Yeah. Go on, go on.
who is in a non-consanguineous marriage. She had presented to us in the second pregnancy at 23 weeks of gestation, which was conceived through IVF, and she had dichorionic diamniotic twins. So in the current pregnancy, the TFA scan showed hydrops fetalis, stomach bubble was not visualized, and clenched fists and bilateral talipes deformity in both the fetuses. And the previous pregnancy also, her first pregnancy also was terminated in view of the similar findings. That was a male fetus. So this was the pedigree depicting the termination of the first pregnancy at 24 weeks with fetal hydrops and multiple joint deformities, and similar findings were present in the current twins.
So I would like to ask Dr. Fahmida, madam. So now that we are seeing this lady, I mean, she's having hydrops in 2 pregnancies, and here now twins, and both are affected. So before we think of genetic causes, I mean, should we keep in mind certain important non-genetic causes of hydrops and how we should look for them, what we should investigate?
Dear Shagun, before I discuss the case given, first of all, I would like to congratulate your effort, because this is the need of the hour. We are getting many abortion cases, recurrent pregnancy losses, high-risk pregnancies. It is the need of the hour because most of the obstetricians are asked to give a solution by the couple. So I think you have taken a very good initiative. I congratulate you as well as
Thank
our
you, ma'am.
OGSH team. And your question, what are the non-genetic causes of hydrops? What is hydrops fetalis first? Hydrops fetalis is a end result of compromised fetus. This compromise is happening because of three major mechanisms. One is severe anemia, second is cardiac failure, third is venous obstruction and delayed lymphatic flow. So once this end result happens, we will see on ultrasound a hydrops fetalis, broadly divided into genetic causes and non-genetic causes. Once you have excluded genetic causes, non-genetic causes are once again divided into immune causes and non-immune causes. Immune causes, as all of you know, it is related to Rh incompatibility. Not only that, once you have to exclude other antibodies like Kel, Duffy, and Kid. If these have been excluded, then you will think of non-immune hydrops. Non-immune hydrops can be defined as a cause which is apart from Rh and its related blood autoantibodies. These once again can be divided into maternal causes, fetal causes, and placental causes. The commonest cause what we see is fetal arrhythmias. It could be supraventricular tachycardias, it could be heart blocks, it could be as simple as severe anemia. Anemia due to twin-to-twin transfusion syndrome or genetic causes like alpha thalassemia, though rare, it can result in non-immune hydrops, parvovirus, and other viral conditions. Infections, here I may ask our director Shagun. We used to think torch is no more is clinically essential, but every time wherever we read, once again we keep on telling torch is also one of the cause. I wish you will clarify me on this point. So cytomegalovirus and other infections can also cause non-immune hydrops, and other conditions like pleural conditions, placental cholangiomas, all these can also contribute to non-immune hydrops. When coming to the maternal conditions, apart from the infections, uncontrolled diabetes, thyroid disorders can also contribute to non-immune hydrops. So the list is on and on. Once you have excluded genetic causes, once you have excluded acquired causes, you should go back to the genetic causes.
So, madam, I mean, one thing for torch infections, of course, I mean, it's mainly the parvovirus infection, which by causing the fetal anemia, most of the times, I mean, that is the one which is more strongly associated with hydrops. And
Are we
like,
able to test this, madam? We keep reading, but practically
yes, madam. Parvovirus serology is available.
available.
Not very easily available, but many labs are doing. IgM, IgG, again, IgM indicating recent infection and IgG past infection. But again, sometimes if suspicion is strong, we can do another test called as IgG avidity test also. So parvovirus serology is available, and then of course the other torch serology is available. Most of the time, the other torch infections, I mean, will not present as only hydrops. I mean, we will have other findings before the baby becomes hydropic due to other, I mean, the classical, the torch group. But another virus which can sometimes cause myocarditis and then cause hydrops is Coxsackie virus. Again, it's very rare, and I mean, I have not seen practically a case, but it's known to, I mean, maybe our fetal medicine colleague, I mean, she may have more experience in that, but that is also known to cause myocarditis and again contribute to hydrops. So mainly these are the more common, I mean, the infectious causes which will be there.
What is
And
your final verdict, Dr. Shagun?
and
Should we do it or we should not?
No, so again, for parvovirus, again, we would first like to look for fetal anemia. So if
Torch, I'm
anemia is
asking
there,
about torch.
the regular torch. So torch, unless there are other features, I mean, I don't know whether we should really, I don't know whether we should do, but all recommendations say we should do. But I mean, so practically I do actually. So because it's
Abroad,
not
I
that
have worked in
expensive.
a recurrent pregnancy loss clinic as a principal investigator for 5 years, prospective study. There, the recommendations were not to do torch, so I have stopped doing torch. But after coming back to India, again, I now started doing so. I'm little bit not clear.
Yes, ma'am. So I mean, there is, that's what, as I said, mostly if there is nothing else, it's very, very unlikely that the only high drops is because of torch. But then most of the places, if we read the textbooks and all, it does say that torch should be checked whenever we have a high drops. So even I find, I have not seen any case where there was nothing else and then it was because of a toxoplasma or a rubella or a CMV causing only high drops as the finding. Usually there'll be other features. If we are seeing high drops as the feature, then other things will also be there. Except of course parvovirus where anemia would be there, or coxsackie where cardiac findings like thickening of walls, echogenicity, poor contractility may be there. So which can again flag coxsackie infection, or again parvovirus can also cause myocarditis. So, but again, if we look into, I mean, the literature, it does say torch should be investigated in all cases of hydrops. So practically I'm doing. I don't know if Dr. Aditi, you want to make any comment on this? Are you there, Dr. Aditi? Okay, maybe we'll ask her when she joins for a session. So, ma'am, but here, like, I mean, we saw this case. So, of course, we have discussed all the acquired causes and we would like to look for them. But in this case, I mean, do you feel there is something else which is a little odd and maybe which may tell us that maybe this family may be having some genetic cause? So, Pratyusha, can you go back and tell us what some other finding was there in this case, no?
Yes, ma'am. So she had the fetuses had clenched fists and bilateral talipus deformity as well, ma'am, along with the hydrops fetalis. In the previous pregnancy as well as this pregnancy.
This pregnancy. So this is something which is little unusual in for an acquired cause of hydrops. So usually we don't expect. I mean, any of those acquired causes causing these clenched, I mean, joint deformities. So that's what here we were strongly thinking from the beginning that probably this is a case because of a genetic etiology. So we'll go Pratyusha next then.
Yes,
So
ma'am.
then, so what all have we investigated here then?
So the maternal blood group was B positive, ruling out RH incompatibility, and the MCA Doppler of both the fetuses was a non-anemic range, and the maternal torch serology was also negative for IgM antibodies.
If the fetus is having MCA normal, then we can safely say it is most probably not an acquired, and blood group B definitely says it is not a RH etiology. Then we have to go back and search again genetic causes. Whenever we get such situation, we should stop thinking about acquired causes. We should start thinking of genetic causes.
So, yeah, so then as you, I mean, mentioned, so we start thinking of genetic causes. So, genetic causes, as in, again, as you said, for the acquired ones, there's a long list. So, even in the genetic causes, there's a long list. So, basically, hydrops is the end result. I mean, it's not a single disease. So, it's an end result of so many different causes, which could be maternal, fetal, placental, and again, within those acquired genetic. So when we think of genetic causes, then mainly what all we consider when there is high drop. So one, of course, is the common chromosomal abnormality. So again, Down syndrome and Turner syndrome. So these are the two commonest chromosomal abnormality which present as high drops. But many other chromosomal abnormalities can present with high drops. Again, here because we are having recurrence, so little bit chromosomal abnormalities become little less likely because most of these Down syndrome, Turner syndrome, most of them are sporadic. Again, they happen due to non-disjunction and they don't recur unless, of course, we have a scenario like we saw in the first case that one of the partner has some rearrangement and that is causing again and again chromosomal abnormalities. So, so that is still possible, but it becomes little less likely. So first, of course, if a single hydrops is there, non-immune, one of the commonest cause around 30% cases will be chromosomal abnormalities, Downs or Turners or others. And then after that, there is a long list of various genetic diseases. So out of which what we are seeing most commonly in India and especially in Telangana is this group of diseases, what we call as lysosomal storage disorder. So they are very common in our population and they are one of the commoner causes of hydrops, what we see in our practice. And then there are so many others, like you mentioned, alpha thalassemia, which is quite rare cause of hydrops for our population. But then there are some skeletal dysplasias, then there are some joint contracture conditions. In fact, here she mentioned that the babies had joint contractures. So what we call as arthrogryposis. So they also present with hydrops. So like that, there are many, many genetic conditions, chromosomal single gene disorders, which present as hydrops as the endpoint and the only finding. And so that's what then.
Hydrops starting early in the pregnancy more indicates towards the genetic causes rather
Yes.
than the late onset of hydrops.
Yes, ma'am. Yes, yes, absolutely. So earlier onset, especially the earlier onsets, we see again more commonly with the skeletal dysplasias and arthrogryposis conditions. There we see first trimester hydrops. Second trimester hydrops comes again in these lysosomal storage disorders and the other genetic anemias. The chromosomal disorders can present as hydrops in both first trimester, second trimester. So, but again, yes, the acquired causes, whatever we thought of, except of sometimes some lymphatic malformation, large lymphatic malformation, sporadic, which may cause early hydrops, but non-genetic. But mostly, yes, early, as you mentioned, ma'am, rightly, the earlier onset is more pointing towards genetic cause. Definitely. And here, like, because there is a recurrence also, so we now start thinking again that maybe it is autosomal recessive condition. Maybe both partners are carriers. That's why their babies multiple pregnancies are getting affected.
Just out of my curiosity, this couple, they are very young couple. The lady is only 25 years. I was wondering why she has gone for IVF. And if she has gone for IVF with the first baby abnormality, why they have not opted for further testing like PGD? I was just thought process.
I'm not sure, Pratyusha, do you recollect any reason why? I mean, it's a little old case. We'll have to check that, I think, why the IVF was
It's
done.
okay.
Yeah.
We'll go further with the routine discussion.
Yes, of course. So now when we start thinking of now what test to do, so how here, because we already have this ongoing pregnancy, so outcome of course with hydrops is non-immune hydrops is mostly guarded. So of course then we guide this couple to they would mostly opt for termination. So here again comes the role of going for again a fetal autopsy and then doing further genetic testing depending on the autopsy findings. So, Dr. Pratyusha, then what has happened here in this case then?
So after counseling, the couple actually opted for termination only, but then they wanted to do the pre-termination amniocentesis for genetic evaluation also. So the amniocentesis was done and the samples were sent for karyotyping and enzyme assay for the common lysosomal disorders which present in utero as hydrops, and rest of the DNA was banked. And
so here's just one point I just want to make. So sometimes no, in such cases like when couple is already decided for termination, they are not very keen to undergo amniocentesis because they want to. Why to kind of they always feel that why should they get poked with a needle and all? They're anyway terminating, so they will do testing on the POC and all. But of course, if the baby is delivered, aborted in a facility where we know how to send the samples for genetic testing, what samples to test. Then even we can, of course, do the test from the fetus when it comes out. But very often it's not possible. Sometimes delivery happens in the night. Some staff nurse will be doing this is just an abortion. So, and they may not collect the correct sample. They will put the fetus in formalin or something. And once the baby goes in formalin, we can't do genetic testing. So there are so many variables which happen and which may compromise genetic testing from a baby which has been already expelled. So that's why we counsel and encourage actually couples to do pre-termination fetal sampling, because then we have a sample which is kind of sterile, less likely to be contaminated with maternal blood, and has been properly collected and properly processed further. So, and in this
Shagun,
case,
at this
yes,
stage, I would like to interrupt, sorry,
yes,
because
yes,
you are
yes.
a knowledge bhandar. We want to extract more information from you. See, there are many PGs have joined in today's webinar. Just for sake of the junior colleagues, you just tell how to collect the sample and from where to collect. Like, for example, collecting the blood from the cardiac chambers. So just
So
can you kindly
after the
enumerate?
baby is expelled, no? After that,
Yeah,
so
after the
yes.
baby is expelled, so that many may get benefit with your information.
So basically, so one thing very important, as I said, no, we once the fetus gets exposed to formalin, then we cannot do any genetic testing, neither DNA test nor karyotype, nothing can be done. So it's very important that a baby should not be inserted into formalin before sample collection. So what sample we can collect? So it depends on the period of gestation also. So if the baby is, let's say, 20 weeks plus, even 18 weeks plus, then in that case, we can try to get some cord blood. If not cord blood, then we can do the intracardiac puncture. So typically between the fourth and fifth rib of the baby, if you just put a 2 ml syringe with the needle vertically inside, you will reach the heart. And then if you aspirate, the blood will come. So that can be collected for older babies. So that is the ideal sample, the blood. And then the blood should be put in EDTA vial. So that is the pink color vial, and not, I mean, like not in the red color, blue color and all. And for karyotype, we have the green color vials, green top. But then most of the time nowadays we have shifted to DNA based testing. So mostly we don't do karyotype that commonly now. So, and sample also will be little only. So instead of putting it for karyotype, we should put it in the pink vial for DNA extraction. So that is the ideal sample. But of course, sometimes blood doesn't come from cord, doesn't come from intracardiac puncture. So then the next best sample. So the next best sample is the skin biopsy of the baby from anywhere. So anywhere on the baby's body, you can take a 2 into 2 centimeter skin biopsy. It's a little bit deep biopsy. It should not be just the epidermis. So little bit deep, containing the epidermis, dermis, and even if subcutaneous tissue fat comes, that's good enough. So 2 into 2 centimeter skin. So then other thing besides that, of course, less suboptimal sample would be the cord segment. So the umbilical cord segment can also be collected, around 5 centimeter of it. The DNA quality from cord segment is slightly poorer, so we don't prefer it. But there are some families who don't want the baby to be kind of skin to be taken or anything to be done. Then cord is a sample you get. So these are the three main samples. The blood has to be in EDTA vial, the skin and the cord has to be normal saline. And it can be stored in the fridge door, not in the freezer, up to 24 hours, and then you can send it to the lab or genetic lab for DNA extraction. Once DNA is extracted, it can be kept for any period of time. It will remain stable. So then after that, we have no fear of losing the sample. So once these samples are collected, then only the baby and the placenta should be put in 10% formalin and then sent for an autopsy.
Do you need placental bit also or no need?
I mean, not really needed, madam, unless and until sometimes, like, no, we have some cases where you have some placental mesenchymal dysplasia or some partial mole picture on the scan. Then we would like to do a placental genetic workup also. So then from the involved area, we can take some placental sample also. And similarly put in normal saline. Otherwise, we don't really need placenta.
Okay, thank you so much.
So yeah, so here then this is, I mean, so these were the
what were the results?
Yes, Pratyusha. So let's move. Yeah.
So they had terminated and submitted both the fetuses for autopsy evaluation. This is the picture of one of the fetus, where we can see generalized subcutaneous edema and some facial dysmorphism was noted. And along with that, we can see the arthrogryposis in the distally, like the clenched fist, and along with the overlapping fingers of the index and the middle finger. And there was bilateral talipus deformity of both the feet as well. So internal dissection was done. At that time, ascites and pleural effusion was noted, and there was hepatosplenomegaly. We can see the liver here and the spleen here. Both appear to be enlarged for the gestation. And similar findings were also seen in the second twin. So both the twins had hydrops fetalis with hepatosplenomegaly and joint contractures. So the most probable diagnosis that we had thought was the storage disorders, and most commonly out of them, Gaucher disease. And the histopathology from the splenic tissue, this is the picture of that. So we can see the foamy macrophages with crumpled tissue paper appearance, which are called the Gaucher cells, which are pathognomonic of Gaucher disease. And the amniocentesis reports had come, which showed a normal karyotype, ruling out chromosomal aneuploidies. And the enzyme assay showed no activity of beta glucosidase, which is an enzyme involved in Gaucher disease, and beta glucuronidase for Sly disease was normal. So because we had a clinical suspicion, Gaucher cells on the histopathology and enzyme assay was absent activity. So directly I had done the target analysis of GBA gene. And in this, we found that in both the twins, there was a homozygous 55 base pair deletion involving the exon 9 of GBA gene. So the final diagnosis is the perinatal lethal form of Gaucher disease, which is an autosomal recessive disorder with a recurrence risk of 25% in each pregnancies. Again, early prenatal diagnosis is possible through chorionic villus sampling between 11 to 13 weeks of gestation.
So, I mean, just for the purpose of, demonstration, and somebody has asked also in the chat. So these are the various lysosomal storage disorder which present as hydrops. And as I mentioned, they are very common for us in our population, because most of them are autosomal recessive, and we have so much of consanguinity in this part of India that itself basically predisposes and increases the risk of all these conditions. So there are various studies. So if we see Western study, we will find that 1% of non-immune hydrops is because of LSDs. Whereas if we start moving towards, there is one preliminary study from AIMS New Delhi, and there are also studies from other consanguineous population like Saudi Arabia. So they show that up to 18% of hydrops cases in population where there is more consanguinity is because of one of these lysosomal storage disorder. And the commonest are the top two, Gaucher disease and the Sly disease. So this is what we actually test when we have a case with hydrops, and we always do testing for these two by doing an enzyme assay, which is a simpler, cheaper test, and that's what gave the answer also in this particular case. So, Dr. Famida, ma'am, any other questions or any other thoughts?
Just a couple of weeks ago, we had one patient who was coming regularly for follow-up, and the only manifestation was fetal growth retardation. So we were trying to evaluate fetal growth retardation. That is the reason we were having serial ultrasound. So suddenly, in the last fetal ultrasound, we noticed first time the baby has fetal ascites. So it has raised the alarm. We got a fetal echo. We showed minimal pericardial effusion, minimal pleural effusion, and there is a significant, and within 48 hours, it became significant. So we counseled and we delivered the baby by cesarean. So the ascitic fluid aspirated was containing meconium. So the diagnosis by the neonatologist, this is a meconium peritonitis. It happens 1 in 35,000 deliveries, very rare. But because of fetal growth retardation, we were regularly screening. And the minute we noticed it is suddenly has increased, we delivered. And thank God the baby is doing well. It is only 1.7 kgs. And they did Laparoscopic and ileostomy. And it seems the prognosis and mortality in such cases is very high. So meconium peritonitis, it is more than 80% mortality, but thank God this baby is surviving and doing well. The reason neonatologist said, okay, the perforation has happened and within short time the baby delivered. So this is the first time we are seeing
Because
fetal
you were monitoring.
peritonitis. And we thought whatever may be the reason we were monitoring, that has helped us in detecting the fetal ascites. So just feel like sharing with you.
Yes, ma'am. So again, even in this
We
case,
thought it was the non-immune eye drops.
yes. But we should still, I mean, again, no, we are always from genetic point of view, so we also still keep possibility of cystic fibrosis in this fetus, I mean, in this baby. So I think we should investigate this baby for that.
Yes.
So we can do this newborn screening,
That's what-
which is there. So that will tell us if that was contributing to the.
That was we thought of.
So
Exactly.
thank
Very
you.
true.
So just to kind of
Thank you so
yeah,
much, ma'am.
just to
Thank you.
summarize it from this case, so what we saw that if we have non-immune hydrops, and especially of course if recurrent, so we should always think of genetic etiologies, and if it is recurrent, then again we should specifically think of these storage disorder. So again, of course, most of these patients would opt for an termination. So then we can, I mean, with the termination, encourage them for an autopsy, because again, autopsy gives us so many clues, like in this case. And sometimes when we get those clues, we come to, a single diagnosis, and we can do I mean, cheaper test or targeted test for the patients, and we don't need to opt for all genetic tests like microarray or exome sequencing, which is, I mean, a huge financial component also. So doing again, I mean, it boils down to the fact that in medicine, even if you have most advanced tests available, it is a clinical picture and the in-depth study of the a patient, I mean, here the fetus, by doing an autopsy, which will actually point you in the right direction and also kind of guide you what kind of test this case needs.
Very true. So thank you so much, madam. Thanks for
Thank you.
sharing your academic platform. I really thankful to you. Thank you so much.
Thank you so much for
Pratyusha,
joining
thanks.
me. Okay, so I think we can move on to the next session then. So Monica, please introduce.
Sure, ma'am. Thank you, Famida ma'am, Shagun ma'am, and Dr. Pratyusha ma'am for this wonderful session. Moving on to the session 4, I'll just present my screen to introduce the next faculty. Yeah. So the final case discussion for this evening is going to be even more interesting for a couple with recurrent fetal anomalies. Now we are turning our focus to a complex and increasingly relevant clinical scenario. And it is my privilege to introduce our faculty expert for this session, Dr. Aditi Shah ma'am, who has joined with Dr. Shagun Aggarwal ma'am for this particular case discussion. Dr. Aditi Shah is an accomplished clinician with expertise in fetal medicine. She holds an MBBS, DGO, DNB, and MRCOG, and has pursued advanced training in fellowship in fetal medicine as well as an international master's in maternal and fetal medicine, UBCN. The case will be presented by Dr. Tushar Palewar, Medical Genetics Resident, Department of Medical Genetics, Nizam Institute of Medical Sciences. Over to you, Dr. Tushar.
Thank you. Hello, everyone. I'll be presenting the last and the fourth case of this webinar. This is a third-degree consanguineous couple married for 3 years, gravida 2 with previous one termination of pregnancy done in view of occipital encephalopathy. In this pregnancy, the current pregnancy, the couple was referred around 12 to 13 weeks of gestation with no maternal comorbidities, and she started folic acid after confirmation of the pregnancy around 4 to 5 weeks of gestation, with no history of fever, rash, arthralgia, bleeding, or teratogenic exposure. This is the 3-generation pedigree showing previous third degree consanguinity, and the previous pregnancy aborted or terminated for occipital encephalopathy. And in this pregnancy, there is a recurrence of occipital encephalocele diagnosed somewhere outside. And this is the axial ultrasound examination was done in our institute, showing the axial view with occipital bone defect, and there is a herniation of the brain parenchyma. What do you mean?
So, yeah, so Dr. Aditi, so now first, like before we go on to, our genetic diagnostic odyssey, so first let's think of common things first. So like we are seeing, so two pregnancies here for this couple with the neural tube defect, of course, a rarer type of neural tube defect, it's an encephalocele. So, I mean, can this be due to folic acid deficiency? And like the second pregnancy, she started it much later, like it was not started preconceptually. So, would that still remain a possibility here?
So thank you, FOGSI, OGSH, as well as Dr. Shagun for giving me this opportunity. And yes, so this particular mother they're in a consanguineous marriage, and this is the second time this thing is happening. So your antennae are definitely going to be up, and you're going to have a checklist in your mind as to why this is happening, and you have to go through the causes one by one. So for an encephalocele, if I'm seeing it properly for the first time, I would elicit a detailed history to ask the mother if she's diabetic, if she's, taking any specific medications like for epilepsy, whether she has had any history of fever in the first, when she was pregnant in the first trimester, and whether, if they are from, any history of exposure to excessive heat like saunas or, things like that also. And then there is also the possibility of chromosomal abnormalities, trisomy 13 and 18 to be more specific. So a more detailed structural survey of the baby to look at the baby from head to toe, and also a more detailed history. But here, because it's also consanguineous, we are more concerned. Folic acid deficiency, yes, but when we have one neural tube defect and generally patients tend to be on folic acid and B12, usually we educate them and we try to start them on both these medications and advise them to take them at least 3 months before planning the next pregnancy. Unfortunately for her, I think she started after confirming the pregnancy. So yes, it could be a possibility, and there are possibilities like when you can have MTHFR gene mutations as well, that you could have this, as probably you will tell us more in detail, Dr. Shagun.
And of course, the second part I think you've already mentioned. So there are so many other, besides folic acid deficiency, so many other factors, as you said, uncontrolled diabetes, hyperthermia, and the other things, the drugs and all, because those also again can cause a recurrence, those kind of things. So those all we have to, of course, keep in mind here. So, so let's see now, as you mentioned, that, we need to do a detailed survey because that will, give us more clues of this case. So, Dr. Tushar, would you like to tell us? So,
Yes.
further, yeah.
As discussed, both non-genetic and genetic causes are possible. Among non-genetic, this folic acid and vitamin B12 deficiency and their metabolic defects, antifolate medications, anti-epileptics, all can also cause the recurrent entity. Among the genetic causes, trisomy 13 and 18 comes considering the recurrence. Trisomy 13 and 18 are the sporadic events, so we will keep it in the down the list. And considering this recurrence and the consanguinity, autosomal recessive disorders like Meckel-Gruber syndrome, Joubert syndrome, and Walker-Warburg syndrome, Charcot-Levin syndrome are the possible diagnosis. The detailed ultrasound examination was done, fetal, and it showed echogenic bulky kidneys and post-axial polydactyly in this. This is the updated 3-generation pedigree of the couple with previous pregnancy terminated for occipital encephalocele, and this pregnancy showing echogenic kidneys, polydactyly, and encephalocele.
So now I think Dr. Aditi, for you, this is so, spot answer. So like, what is your impression now that, we have this recurrence and we have this additional scan findings? So what do you think this baby has, and how would you like to counsel this couple now? You're muted.
Sorry. So the first thing is that they're consanguineous. So you're looking at an autosomal recessive condition, which is likely to occur in every pregnancy, about 1 in 4, that is 25% risk of it happening again. And with this classic triad of post-axial polydactyly with, echogenic kidneys, enlarged echogenic kidneys, as well as occipital encephalocele, we are thinking of Meckel-Gruber syndrome. So that would be our first impression. And yes, we would like to send the baby for detailed postnatal examination, as well as do a test on the fetus, as well as, after we establish in the fetus, the parents as well, to understand whether they are, carriers, and what other carrier status is there as well, because they are consanguineous. So how would we counsel them? Yes, we would counsel them. So we have to walk a thin line. We cannot, just say that blame the consanguinity, because that can have consequences. So we have to tell them that because, they are married in relation, there is a possibility that they may share a same gene pool and they could have these defects happening. So we would first like to investigate the baby, the index child or the index pregnancy that is affected, so that we have a diagnosis, a confirmed diagnosis, and then subsequently evaluate the partners as well, and also offer them additional carrier screening, because we don't want other surprises coming our way in the next pregnancies.
So let's go to next slide then, Dr. Shah. So I think, like, as you said, so these are the things we, of course, will be doing. And of course, you already mentioned the autopsy. So, but I mean, the test now, what test to choose? Like, so, like, we saw in the last case, like we had a single diagnosis, Gaucher disease. So we were not, I mean, that couple did not need an exome sequencing. We were able to just do target sequencing of the gene. So here also we have a single diagnosis, but the problem here, what happens is that Meckel-Gruber syndrome, although it's a single disease, but it can be caused by, it's known to be like what we call as genetically heterogeneous. That is, there are various different genes, mutations in which are known to present with the same clinical picture of Meckel-Gruber syndrome. So here it's not so straightforward, our testing. So so here mostly we go for an NGS based testing. That's again exome sequencing, because an exome sequencing helps us sequence all the coding regions of all the genes which are there in our body. So whichever gene is involved in this particular family with a mutation will be picked up in that testing. So that's the test, of course, here which we would want to do. There is no role of doing a microarray here, because we already know the diagnosis and we know it's a single gene disorder. So it's not going to get picked up on a microarray or a karyotype. So an exome sequencing is what we are going to do here. And then, of course, this is a second question which we often get asked by the families also, that why are you even wanting to do a genetic test? This is anyway a poor outcome scenario. So why to bother and all? But I mean, as we have seen now through the previous 3 cases, so genetic testing, helps us in finding the exact mutation. So of course, here we are presuming a diagnosis, so we need to confirm it. So it's a genetic test which will confirm it. And it will also find the gene and the mutation which is involved in that particular family, because that will come in handy for planning their subsequent pregnancy. So that's why it is still to be done. So even if you are faced with a situation where there is a lethal finding in the fetus, even if it is a single pregnancy. So here there is a recurrence, but even if there is a single pregnancy with a lethal malformation where the family would be just wanting to go for termination, then also we have to encourage them to do all these additional things, because that is what is going to help them for the next pregnancy.
And this whole exam you would recommend, Dr. Shagun, on the pregnancy or on the post-abortal fetus?
So any, like, as we had the discussion in the previous case, so if we are sure that the post-abortal tissue will be, collected properly and the person doing the abortion knows how to collect the correct tissue and store it properly, transport it properly, then it can very well be done on the post-abortal tissue. Then we don't need to do a prenatal sampling, but that is the ideal scenario, which is not often there. Often these patients come from interiors and they travel to our centers, but they want to go to their hometown for the abortion, of course, for the family support and everything. So then there, of course, it's very difficult to coordinate the sample collection, sample transport. So we try to encourage them for a prenatal sampling if we feel that that's the scenario.
And in this kind of a scenario, would you offer them trio-exome, or would you wait for the results of the fetus and then go ahead? And what would you offer the couple? Like, would you just say that do this because this is the gene that we have picked up in the index child? Or would you offer them additional carrier screening? What would you do, Dr. Shagun?
Yeah. So I think we are coming to that later, but yeah, basically, it's a very, very, kind of pertinent questions here. So usually, I mean, the ideal test, of course, is always a trio. So whenever we are suspecting a genetic disease in a fetus or in even a postnatal case, I mean, the ideal thing is to do a trio exome sequencing, even if the couple is non-consanguineous, because just doing sequencing of the proband, sometimes we get some, variants of uncertain significance. We get certain, especially when there are dominant disorders, X-linked disorders, we get some variants which are not really clear cut. So we need to then check them in parents to see whether they are de novo, inherited. So, I mean, there are a lot of complexities. So just doing a solo exome often does not give us an answer, and we further have to then again do a parental testing, either target testing or an exome. So to save time, and if the family is affording, and especially if they want to, in a pregnancy, if they want to wait for the report before deciding, their ideal is to do a trio-exome sequencing, because then you are really kind of, within 1 month, you will have the parents and the baby's reports. You would have a kind of segregated as in, I mean, if this fetus is homozygous, you would have confirmed that parents are heterozygous for an autosomal recessive disorder. If the fetus is found to have an autosomal dominant disorder, and then we would have confirmed, ideally, if that is a disease, then parents will not have that variant. So it will be de novo. So many information will come from doing a trio, and which will, kind of save your time. So that is very critical when your pregnancy decision depends on the report. So then though you should do a trio if pay, but the reality is that most of the patients, they don't afford. They don't even want to, kind of do a exome also because of financial constraints. So doing a trio is like, even, triple the cost. So that is what happens in reality, that we end up doing a solo exome. And in this family, as you rightly said, because they are consanguineous, so then, as you said, we don't want to miss something else also. So again, consanguinity per se is a major risk factor for autosomal recessive disorder in the offsprings. And there are around 2,000 plus autosomal recessive disorders which are known to medical science. So we have, in fact, seen in our own cohorts by doing, we have done studies for this consanguineous couple, and we are finding that a large number of consanguineous couples are carriers of at least one disease, and some are even carriers of 2 or 3 or even 4 diseases. So that is where, like, these two, doing a parental exome, especially in this family, is an additional benefit. So not only will it help in this baby's diagnosis, it will also help in finding whether the couple are carrier for any other autosomal recessive disorder which may happen in their subsequent pregnancies. So this couple would have this additional benefit by doing a trio. So that's ideal, but again, ideal doesn't always work. So we can do it as a later step.
How important is it to correlate the genotype with the phenotype? Because a lot of times the patients say, already I know what is there on scan. Why should I do an autopsy? So how important is it to do an autopsy? And would you recommend it for any anomalies that you see on scan?
Absolutely. Even in this case, in this case, it's like almost a spot diagnosis. I mean, I'm not thinking of many other differentials, but I mean, nature or science always has a way to surprise us. When we are most sure of something, it kind of, tells you, no, wait, there is so much more you don't know. So there are always surprises. So we should always do an autopsy. So even if here it is a clear-cut diagnosis, or in cases where there is a single anomaly and there is no working diagnosis, because autopsy, I mean, will give you additional findings. So there are so many things we can't see in ultrasound. Most of them are related to the facial appearance, which we call as dysmorphism in genetics. And in addition, there are some malformations also, which can get missed on scan. So autopsy gives us additional additional findings. It helps us in coming to some diagnosis. Like in that Gaucher case, what we saw, it was histopathology, which kind of clinched the diagnosis for us that this is Gaucher disease. So there are so many components of autopsy, and each one of them has an important role to play in the phenotyping, as you mentioned. So the phenotype guides the test choice of test also. And sometimes if you already have a test report also, then it helps in correlating so what will happen in an exome, sometimes 3-4 diseases come. Okay, where baby has this mutation also, this also, this also. Some of them are variants of uncertain significance. So then when we correlate, then which one, which is correlating, what phenotype correlates with the mutation, then that is how we kind of reclassify or upgrade certain variants. So autopsy helps in that phenotyping, which will help you in interpreting your genetic report. So it's really critical.
And you can do an autopsy on a 12-week fetus as well, because this is a 12-week fetus. So I think the message should go out, Dr. Shagun, from you, that from when onwards can you do a fetal autopsy?
Yes. So 12 weeks onwards. So 12 weeks is what we usually do. Before that, we don't really do, because it's too small to see anything. So beyond 12 weeks, so as I had mentioned earlier also, so any pregnancy, unexplained pregnancy loss beyond the first trimester needs an autopsy. An autopsy and a genetic workup, again, depending on the findings and all. Even if single, and without a malformation also. So, Dr. Shah, yeah, let's see. So what was the autopsy in this case?
Keeping this particular diagnosis in mind, we explained the guarded prognosis to the couple, and couple agreed for the pre-termination prenatal genetic testing. And the CVS was done, and fetus was submitted for the autopsy. This is the gross autopsy findings showing facial dysmorphism and post-axial polydactyly in the left upper arm, and the dorsal photograph showing occipital bone defect and occipital encephalocele. And the whole exome revealed there is a likely pathogenic homozygous nonsense mutation variation at complementary DNA position C.2762, where thymidine is replaced by the adenine in CEP290 gene associated with the autosomal recessive Meckel-Gruber syndrome 4. Based on this, we explained the genetic basis of the diagnosis, and the autosomal recessive pattern of inheritance was explained to the couple, and with a recurrence risk of 25% in the subsequent pregnancies. And also, as in Indian population, the carrier frequency for the beta thalassemia and the spinal muscular atrophy is quite high, amounting around 3 to 5% in certain population. So routine carrier screening for beta thalassemia and spinal muscular atrophy was also offered. And keeping in mind third degree consanguinity, expanded carrier screening for other pathogenic or likely pathogenic mutual carrier status, it was offered, along with routine antenatal care and periconceptional tablet folic acid.
So we go to next slide. So I think
Shagun, can I just stop you here and ask you?
Yes.
Can you please explain the difference between routine carrier screening, expanded carrier screening?
Yes, so routine carrier screening is what we recommend for all couples. So, which is what Tushar mentioned, thalassemia screening and SMA screening. Again, thalassemia screening, too, there is no excuse why it should not be done. It's cheap, it's easily available. So, every couple planning a pregnancy should have thalassemia screening. SMA screening also, we advise our society, Indian Academy of Medical Genetics. We have come up with the guidelines and we recommend for everybody SMA screening also because 2% of our population is carrier of SMA. So again, but doing SMA carrier screening is not so straightforward. So it's available mainly in genetic labs and it's a little bit expensive. So it's a little difficult to implement, but we should at least try to do. At least the patients who are able to do, we should encourage them to do. So that is routine carrier screening, basically for everybody, irrespective of consanguinities, irrespective of which part of India they are coming from. Because this is like pan-Indian carrier frequency is really high. Expanded carrier screening is something which is kind of screening for conditions beyond the routine. So those are something which we kind of recommend as of now. So for Indian population, because we don't have enough data available. So for other populations, there is data available as in what diseases are prevalent in their population. So what is the carrier frequency of different diseases? They have that available. So they are able to offer carrier screening for those diseases also. So that becomes a kind of an expanded screening. But unfortunately for our population, we don't have that data. We know some common diseases, which all our geneticists and US fetal medicine practitioners see some diseases more commonly. But we still don't know, like, the top 100, top 200, and we are so different, so many, ethnic groups in our population, which group, what is more common. Beyond a few conditions, we don't know. So at present, we don't kind of recommend these kind of expanded carrier screening, which are done through exome sequencing for general population. But we do advise these for couples who are having previous, offsprings where we are strongly suspecting that there was a genetic condition. So like we saw in the second case, so there we would advise. And consanguineous couples also sometimes nowadays they are coming and asking for it. They are kind of coming, they are aware that they have increased risk. So they come and they ask, can we do any test to find out whether we are carrying any genetic diseases? So for them also we suggest that, okay, if you wish, you can do. But there is no Indian guideline as of now saying that expanded carrier screening is to be done for everybody. We restrict it as a recommendation only for couples who have had, where the family pedigree is suggesting that this couple may be carrier of certain genetic disease. Then only we advise.
And in this particular scenario, at 12 weeks, scan findings were quite significant and you could make out on scan. So, I mean, why should the patient spend for a whole exome or a trio exome? Why not wait, get pregnant and, just wait for the next 12-week scan, then diagnose or, if it's fine, then it's fine. What do you say to this kind of a question from the patient?
Yeah,
And
yeah.
from the
So,
gynecologist as well.
yeah. So, I mean, of course, this case is almost a spot diagnosis, and that's what we suspected. That's what it turned out to be. But, again, as I mentioned, there is so much of variability in genetics, which we see that, we are thinking of some condition, but the baby may actually have some other disorder. So, which we have not even heard of. I mean, literally nowadays, every week, one new genetic disease gets discovered. So it's still possible that this fetus may be having something else. And then there are some genetic condition which have a variable expressivity in the same family. So two individuals, same mutation, one fetus may be showing all these findings, second fetus may not show anything in scan and may have intellectual disability after birth. Not in this condition. Meckel-Gruber will always manifest. But I'm saying some similar conditions may be like this. So, so both for the purpose of confirming the diagnosis and of being, make sure that it is, not a condition with kind of variable expressivity. So to be sure by doing a molecular testing and, even if scan looks normal, still going ahead and doing a testing, that's ideal. And of course, the other option which becomes available to such couples once we have the genetic report is a PGT-M. So because 25% recurrence risk, again, doesn't occur in any order, no. So it like here also twice it happened. So third, sometimes just by sheer bad luck, that 25% risk is every time. So some couples end up having 4, 5, consecutive babies being affected. So it's such a huge trauma to them. So once we have the genetic report, then they can opt for an IVF PGT-M to kind of, bypass this recurrent affected fetuses and the terminations and the trauma also which comes with that. So for all these reasons, we would still, want to always do a genetic testing. So I think we'll end here. So whatever we have seen here, so recurrent anomalies, especially again, recurrent we are saying here because this session is on recurrent, but again, as I mentioned, even a single anomaly needs investigation. But of course, if they are recurrence, we should think of all these causes: autosomal recessive disorders, balanced chromosomal rearrangements in parents. Sometimes if all babies are males, then some in maternally inherited X-linked recessive disorders, and rarely sometimes a microdeletion, microduplication, or autosomal dominant disorder inherited from a parent who is not manifesting the mutation. This also can happen. So these are often, if there is a recurrence, is very likely to be a genetic cause. We should definitely investigate. And of course, as we saw here, doing a good ultrasound often can, make you reach a single diagnosis also, and thereby guide your testing and subsequent kind of guidance for the reproductive further planning also. So, Dr. Aditi, any other final words from you? Otherwise, I think.
No, I think you have covered it brilliantly in all the cases. Thank you so much, Dr. Shagun. Just one thing, we had a case, 2 cases actually of hydrops where the mothers had thiamine deficiency. So after excluding everything and then working it up, we found that the mothers had thiamine deficiency. That was one interesting thing. And just anecdotal, like we had a couple who had bilateral renal agenesis and somehow they wouldn't accept it. Finally, they did an autopsy which confirmed it and it found, Fraser's syndrome. So it's just to emphasize, as you said, that always investigating anything and everything will give you a lot of clues and will give you pointers to their next pregnancy to guide it in a better way. Thank you so much, Dr. Shagun, and thank you, OGSH as well.
Thank you, Doctor. So I thank all the presenters, all the moderators for their participation, for all the discussions. So,
Shagun, we will take one group photo.
okay, and share these slides.
I think that was a brilliant webinar, Dr. Shagun. Congratulations. Very, very informative and very useful. And we have taken so many points home. I think everybody will agree who has stayed back and listened to everything. Wonderful. I think we are looking forward to a feast of such webinars in the future. Congratulations to you, your
so much,
team,
Dr.
to all the faculty who participated. It was such an interactive discussion with all the faculties.
Manju, thank you
I
so
think-
much for giving us an opportunity. Thank you so much, Shagun and your team. Thank you.
Congratulations, Dr. Shagun.
Thank you for all the all the co-moderators. I mean, it was wonderful having everybody, and for the wonderful discussion. So I think the group photo.
All of you can join and smile. 1, 2, 3, take. Monica disappeared. Why? I don't know. Right time she disappeared.
Ma'am, should I be there? I thought
Yes,
it's a
of course.
photo, so
You are the manager behind and front. Yes. Once again, 1, 2, 3, take. Thank you. Thank you all
Thank
of
you, ma'am. It was a privilege.
Right.
Thank you. Thank you so much,
Thank
ma'am.
you.
Thank you, Manjula, ma'am.
Ma'am, as
Thank
such, all
you.
the Q&As have been wonderfully addressed by the faculty members.
There's still some questions about APLA.
Yes.
I don't know if, Dr. Meera, you want to answer
Yeah,
those?
I did answer. Yeah, all the answers are there.
Yes.
Okay, good. Yeah.
Yes.
So I think there's one question about if NGS is person dependent or done by a machine.
Yeah, so it is both actually. I mean, in the sense that the initial preparation part is manual, of course, but eventually, of course, the sequencing is completely machine dependent. So, but then again, once the machine does the sequencing, then the interpretation also is person dependent. There also, of course, now AI is coming in, but then still we know there are a lot of limitations. So, of course, person before, after the NGS remains a very critical component of doing the test.
Absolutely, ma'am.
Most other things are answered, I think, no?
Yes, yes.
Yes.
So if any other faculty member, guest member has any questions, they can raise their hand. Maybe we can unmute them and they can ask the question.
When the participants can be, unmuted if they are
Yes,
talking to
yes.
us. So if
Any
anybody
of the
else has,
participants can be unmuted.
I
Once they
think,
raise their
Shagun,
hand, we will unmute.
the machine is important, but women behind the machine is more important.
yes.
Bye and good night to all of you. Thank you.
Okay, bye. Good
Thank
night.
you.
Thank you. As we reach to the end, I would like to extend a heartfelt gratitude to each one of you, ma'am. And I truly am humbled and deeply nostalgic to have this opportunity to host this meaningful session. I would like to invite Mr. Dhruvjyoti Bandyopadhyay, who is the Vice President of Sales and Marketing for Unigenome and Unipath, to deliver a formal vote of thanks. Thank you. Dhruvjyoti, sir.
Good evening, everyone. First and foremost, I extend my heartfelt gratitude to Dr. Shagun Aggarwal for all continued support, and for graciously giving us the opportunity to collaborate. Ma'am, your encouragement has been instrumental in making the webinar possible. We also extend our sincere thanks to OGSH for trusting us to host this academic initiative. Your confidence is serve as great motivation to contribute meaningfully to the medical community. A note of appreciation to all of distinguished panelists, presenters, and discussants. Thank you for sharing your valuable expertise, your perspective, and for your engaging in such thoughtful and insightful discussion, madam. Your contribution transformed this webinar into a truly informative and intellectually stimulating session, ma'am. We are equally grateful for all the attendees for taking time out in their busy schedule to join us. Your participation, questions, enthusiasm reflects a commitment we all share towards advancing clinical excellence and improving the outcomes. We'd also like to acknowledge the efforts of organizing team and my PMT team, madam. At Unipath, we always remain committed for supporting clinicians with the best advanced diagnostic solution and meaningfully academic collaborations. Thank you once again to each one of you for making this webinar a memorable and successful academic event. Thank you so much, ma'am.
Thank you. So, yes, good night.
Good night. Good night.
Thank
It was a
you.
pleasure moderating. Thank you.
Thank you.
Good night. Thank you, sir. Thank you, everyone. Thank you. Suresh, you can end the session.
Yes.
Thank you, Suresh.
Thank you. Thank you, ma'am.